Allora, buon pomeriggio a tutti, grazie di essere intervenuti, faccio questa piccola introduzione in italiano per spiegare alla Commissione che ringrazio, ai candidati, ai presenti, che questa è una sessione di laurea un po' particolare che in pratica si articola in due parti. C'è una prima parte internazionale dedicata ai laureandi del corso di laurea F, del corso di laurea in Medicine and Surgery. Questa parte sarà ovviamente in lingua inglese. Ci sarà chiaramente la prima proclamazione dopo i candidati del corso di laurea F e poi ci sarà la discussione dei candidati invece degli altri corsi di laurea in italiano. Questo solamente per fare una breve introduzione e per spiegare come in pratica si struttura la sessione di laurea di oggi pomeriggio. Now I have to start to talk in English because this is the starting of the English, the international session of this the final exam of the thesis. It's time to start. Good afternoon to everyone and welcome to this the final exam of thesis. This is the graduation day of the international degree course in medicine and surgery of Sapienza University of Rome. Let me introduce myself very briefly. My name is Paolo Villeri. I am professor of hygiene and public health at the University, and I am also the president of the degree course in medicine and surgery. Professor Carlo Della Rocca, the dean of the Faculty of Medicine and Pharmacy, asked me to replace him in chairing the committee. And I am very glad to do that. First of all, I would like to make a special thank you to all the professors. Thank you very much for coming. And I think that you candidates are very lucky because today, this afternoon, you have the possibility to discuss your thesis, the results of your work on the thesis, your finding in front of this commission. And I'm sure that there will be a very useful and stimulating discussion. The day of the final exam of the thesis is a very important day because it is the conclusion of a very long pathway during which you spend a lot of energy to prepare the exam, to follow the lecture, to study, to pass the exams, and also to prepare your work, your final work of the thesis. But this day is a sort of ceremony, and since it is a ceremony, I think that it deserves an appropriate atmosphere. We have a sort of behavioral code to respect. There are some words in Italian that are very difficult to translate in English. The one of this word is sobrietà. I don't know how to translate it in English. The sobriety, moderation. I think that we have to respect this behavioral code, not also in this room, but also outside the building and also outside the university. This is very important because I repeat it again. This is a ceremony, and it deserves a very appropriate atmosphere, a sort of special atmosphere. I think that again, you candidates are very lucky because today we have the possibility to come back to the traditional environment after in presence after the lockdowns due to the COVID-19 emergency. We all have to follow all these safety measures, but we are very glad to do that. And I think that you, students of Sapienza and graduates from Sapienza, you have a special duty because you have to transmit these safety measures also outside the Sapienza community, with your friends and your parents and your families and so on. For sure, these months have been very difficult for all of us, for we professors, for you students, due to the COVID-19 emergency. But I'm sure that we all are stronger after this experience. In conclusion, this is an important moment of your life because you are becoming physicians, qualified to exercise the profession immediately after the ceremony. You know that. So without the need of a state examination. You candidates probably will be recorded as graduates at the times of COVID-19 emergency. I think that you have to be proud of that, and particularly I think that you have to be proud about the fact that you are becoming physicians graduated by the International Medical School of Sapienza of the University of Roma. Please do not forget this for life. Okay, after this very brief introduction, I think that it's the time to call the first candidate. The first candidate is Sigal Noy Ladinsky. Please, Sigal Noy, please, just a second. There is a little change, I'm sorry, the Professor Cangemi. Sigal Noy Ladinsky is presenting the thesis. The title is Targeted Therapy in Pediatric Low-Grade Glioma, the experience of Bambino Gesù Children's Hospital. The supervisor of the thesis is Professor Franco Locatelli. Please, the professor, to introduce briefly the candidate and the work of the team. Thank you.
So many thanks, and dear distinguished colleagues, ladies and gentlemen, dear students, good afternoon, first of all. For me, it's a great privilege and a pleasure to introduce Ms. Ladinsky Sigal Noy, who was followed by me during the preparation of her MD thesis. In particular, Ms. Ladinsky prepared a thesis on childhood low-grade gliomas, which are the most common histological variants of brain tumors. This type of tumors are conventionally treated with surgery and radiotherapy, but in some selected cases, either of the two approaches cannot be applied. Considering that and the pathophysiology of these brain tumors, there are classical alterations involving the mTOR and BRAF pathways. The candidate prepared a thesis reporting the safety profile and the efficacy of two approaches, one based on the use of sirolimus, which is a typical mTOR inhibitor, and the other one being based on the use of bepuranimab, which is another selective agent capable to interfere with the BRAF altered pathway. So the thesis is a classical and I would say prototype model of precision medicine, and we will be all pleased to hear the results. Please.
Thank you very much, Professor Locatelli. Thank you, your committee, and thank you to my family and my friends that are here and watching now. Primary tumors of the central nervous system are the most common solid tumors in the pediatric age. The annual incidence for the age group between 0 to 19 are about 6 cases per 100,000 population, with a slight higher difference. The prevalence is about 22 cases per 100,000 population, when the most common histologic type is pilocytic astrocytomas. The most recent classification that is used is from 2016, which is the World Health Organization classification for central nervous system tumors. The etiology for these tumors in the pediatric age is elusive, but the only ionizing radiation is the most and well-validated risk factor that has an increased risk for brain tumors. There is a subset of patients that they have predisposition syndromes, and that they can develop brain tumors due to germline mutations. And the most common are neurofibromatosis type 1 and 2, tuberous sclerosis complex, and others. Pediatric low-grade gliomas are considered WHO grade 1 and 2, and have a characteristic histology of glial cells, and which have an indolent course. They are the most common brain tumors in children, with median age of diagnosis that is between 6 to 8 years old. And the prognosis basically depends on the age of diagnosis, on the location or functional site of the tumor, and its biomarkers. The overall survival is around 90%, and of which in many children a residual tumor remains, and therefore nowadays it is considered as a chronic disease. The molecular biology of pediatric low-grade gliomas are extremely different from the adult ones, and are characterized by different molecular alterations. In most of these tumors, the MAPK signal transduction pathway is involved, and there are activated mutations or rearrangements of the BRAF gene, or hyperactivation of the mTOR, which are the hallmarks of pediatric low-grade gliomas. The standard of care in the treatment for these tumors is surgery with complete resection of the tumor with curative intention. If gross total resection is achieved, the prognosis is excellent. But when a gross total resection is not achieved, and there is radiological progression of the tumor or worsening of the clinical symptoms, then an adjuvant therapy is required. In this case, it is used chemotherapy and or radiotherapy. This traditional approach leads to short and long-term toxicities and morbidities, and worsening the children's quality of life as well as their families. Therefore, a new therapeutic approach is required. The main goals of the study is to propose a safe and efficient new therapeutic approach that will not be inferior, that will stabilize the disease, reduce the toxicity and the morbidities, and preserve the quality of life. It is an experimental retrospective study of a single center that analyzed the data of 17 children together in these two studies that they were diagnosed histologically with low-grade gliomas that were positive with the immunohistochemistry to mTOR or phosphorylated mTOR or BRAF mutations, V600E. We evaluated the efficacy and safety of everolimus, which is an inhibitor of mTOR, and of bemorphenib, which is an inhibitor of the mutated BRAF V600E protein in the children that they were not amenable for a gross total resection, and they were not related to tuberous sclerosis complex. 7 females and 3 males with median age of diagnosis, which was 7.3 years, diagnosed with low-grade glioma with positive to mTOR, were enrolled to the treatment with everolimus. These children had all the the treatment started after a radiological progression of the tumor with the growth of the tumor volume, or upon deterioration of the clinical symptoms, or upon diagnosis due to the location of the tumor that caused focal motor deficits. The starting treatment, the median time to start treatment was 21 months after diagnosis, with a median duration of the treatment that was 19 months. And the starting dose, that was 2.5 milligrams per day or 5 milligrams, depending on the weight of these children. The results during the follow-up, the children were followed radiologically and clinically. And we observed 80% positive response to treatment, whereas 70% had stable disease with median time to reach the best radiological response that was 9 months. One patient has a partial response that was achieved after 18 months of the treatment, and 2 patients had disease progression, one after 18 months and the second one after 36 months. Also, it's important to mention that 90% of these patients had a clinical stability during the entire course of the treatment without deterioration of the symptoms. The treatment was well tolerated by the patients with only few side effects. Only each patient had at least one symptom, but at least one adverse effect, but there were mainly stomatitis, dry skin, alteration of lipid metabolism, and most of them were very mild. The second, for vemurafenib, where we had 1 female and 6 males with median age of diagnosis at 6.3 years. They diagnosed histologically with low-grade gliomas, positive for BRAF V600 mutation. 6 of the tumors were located infratentorially, and 1 of them was supratentorial, and all of them were WHO grades 1 or 2. Treatment also here was started after a radiological progression of the tumor or after worsening of the clinical symptoms. The starting treatment, the median time was 17 months after diagnosis, and the median duration of the treatment was 22 months. The starting dose was 240 milligrams per day. It was administered orally, and there was a gradual adjustment of the dose, which was based according to the toxicities and the efficacy to the treatment. Also, this treatment was well tolerated by the children, and they are seen only exclusively skin toxicities, which were mainly expressed on photoexposed areas, and it was needed to suspend the treatment only temporarily in 1 child, and after reintroduction of the treatment, this side effect was not appeared again. 4 patients positively respond to this treatment, which account for 57% of the cohort. 1 had a complete response, which has been observed after 6 months of the treatment. 2 had partial response, 1 stable disease, and 1 progression of the disease. In all of these children, there was an improvement of the neurological functions that was observed after only 2 weeks from initiation of the treatment. We analyzed the progression-free survival in both the treatments according to the Kaplan-Meier curve, but of course it's a small sample and it's not statistically significant. So we can conclude that the response to treatment was observed with both drugs. Both drugs had shown promising efficacy and tolerable safety profile, represented suitable option to be used as a target therapy in pediatric low-grade gliomas. Both of the drugs can provide precision therapy that targets pathway alteration and inhibits the activity of this molecular alteration. They are administered orally. They provide a suitable alternative to the traditional approach, and they are not inferior to the traditional one, and they show very good radiological and the clinical responses with preservation the quality of life of the children. Of course, further studied with larger cohorts are required, but I can conclude and say that this chemotherapy and radiotherapy-free treatment should be considered as a first-line therapeutic approach. Thank you.
Okay. Thank you very much. Thank you very much. Thank you very much, and congratulations for your presentation. Are there not any questions by the commission or by the professor? Professor Merli, I think that you should come here. I'm sorry. Please, the signal noise. Just Okay.
Very nice presentation, and my question is just naive. I saw that they were treated after 21 months and after 17 months. This is because after the diagnosis, in any case you wait. I mean, why they were not treated for about 2 years? Okay.
You start to treat the children. You can if you can't reach the resection, you have two options: observation, or you can treat the patient. If there is no radiological progression of the tumor, or there is no worsening of the clinical symptoms, then you observe it. When you reach deterioration or a progression of these tumors, then you can start the treatment. Did I answer your question?
You are the supervisor of the thesis, they have to ask you if you are formally satisfied about the candidate and the work of thesis. Please.
Yes, absolutely. The candidate participated in a very passionate way in the analysis of the data and the preparation of also scientific paper that was recently published on this issue. And she demonstrated a great enthusiasm and studying the most innovative approaches for treating children with this type of brain tumor. I can just wish all the best for the candidate's future professional career, and I am sure that if she will continue in this way, she will be an excellent doctor. Thank you.
Thank you very much.
Thank you. Thank you very much. This is nice. Thank you very much, and then congratulations again. So it's time to call on the second candidate. The second candidate is Livnat Alon. The Livnat Alon is presenting a thesis. The title is Risk of Cardiovascular Events in Patients with Non-Alcoholic Fatty Liver Disease, a systematic review and meta-analysis. The supervisor of the thesis is Professor Cangemi. Please, the Professor Cangemi, introduce briefly the candidate and the thesis. Please.
Ladies and gentlemen, good afternoon. It's a great pleasure for me to introduce Livnat Alon. She's a very talented student, and in these times in which we cannot allow students to attend awards, she had a lot of time to study and used this time to perform meta-analysis to understand, to better understand the link between NAFLD, non-alcoholic fatty liver disease, that is one of the most common diseases, and its association with the cardiovascular disease. In particular, she will show which cardiovascular disease is more associated with non-alcoholic fatty liver disease, and if there are factors that can change this kind of association. Please.
Thank you, Professor Cangemi, for the kind introduction. Today, I will present to you a systematic review and meta-analysis on the risk of cardiovascular events in patients with non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease is a spectrum of conditions ranging from steatosis to steatohepatitis with or without fibrosis, and then its most severe stage cirrhosis. It has multiple risk factors for development and progression: gut microbiota, sedentary lifestyle, dietary habits, and dietary habits are all contribute to the development of non-alcoholic fatty liver disease. It's currently known to affect around 25% of the general population worldwide and has strong correlation with type 2 diabetes and obesity. Non-alcoholic steatohepatitis is predicted to be the primary indication for liver transplant between 2020 and 2025, making it a serious healthcare system problem. Unfortunately, currently there is no significant pharmacological advances to this condition. We chose to focus on the correlation of that cardiovascular diseases are one of the leading causes of mortality in NAFLD patients. So NAFLD patients and cardiovascular diseases share common ground, such as common risk factors, lifestyle, and metabolic dysfunction. NAFLD has also shown that it can promote pro-atherogenic lipid profile, endothelial dysfunction, and oxidative stress. Cardiovascular diseases are among the main determinants of death and poor outcome in NAFLD patients, as mentioned before. We aim to better understand the link between NAFLD and cardiovascular diseases by firstly include recent large studies done on this topic. Secondly, to address specific cardiovascular conditions, such as atrial fibrillation, heart failure, ischemic stroke, and myocardial infarction, which are the outcomes of this analysis. And thirdly, to explore a link to other factors that may affect the results by performing meta-regression and subgroup analysis. In this, our vision was to include as many articles as possible. Our inclusion criteria was to include studies that reported the number of patients with or without NAFLD, to include one or more of the outcomes mentioned before, and all studies with a minimum follow-up of 1 year. Our exclusion criteria was to exclude those studies that do not report the number of events according to NAFLD status, cross-sectional studies, articles that are not in English, a conference abstract, systemic review, and meta-analysis, and also highly selected cohorts, such as patients with previous cardiovascular events. We chose PRISMA protocol for our search and screening methods. The search was done by two databases, Embase and PubMed. Primary and secondary screening were done independently by Dr. Omid and myself. The primary screening was done by reading abstract and title, and secondary screening was done by reading the entirety of the article. We received 20 articles for this analysis. It's important to note that for some of the studies, there were more than one outcome. Therefore, 13 studies were on a myocardial infarction, 12 studies were on ischemic stroke, 7 on atrial fibrillation, and 4 on heart failure. So here you can see the primary analysis done on myocardial infarction. Here you can see the study, which the two groups, non-NAFLD patients and NAFLD, and here is the total number of patients included in this analysis. In this forest plot, you can see here a confidence interval showing a significant link between a NAFLD patient and myocardial infarction. Here, it's the heterogeneity percentages. This is the results for ischemic stroke. The same a significant link between NAFLD and ischemic stroke was shown in the primary results. Atrial fibrillation. Here also you can see that is a significant correlation link between NAFLD and atrial fibrillation, and here for heart failure, shown here. In the meta-regression analysis, we checked on some modifiers. At univariable analysis, cohort studies and NAFLD definition by ICD codes were significantly associated with an increased risk of myocardial infarction in patients with NAFLD. In a multivariable model comprising the study level of mean age, the proportion of male enrolled, and type of study, explained the between-study variability that we found in the primary analysis, with the proportion of male patients inversely associated with the risk of outcome, which was higher in cohort studies. For the risk of ischemic stroke, we found that mean age cohort studies, type of diagnosis by ICD codes, and high risk of bias in geographical location were all associated with the outcome, with mean age being able to explain almost all between study variability. However, unfortunately, we didn't find any significant moderator that associated with the risk of atrial fibrillation or heart failure. So to conclude, we found that non-alcoholic fatty liver disease is associated with increased risk of all outcomes checked in this analysis. Geographical location and criteria used to define NAFLD may influence the extent of this association, and age and male sex may represent a key moderator, but further studies are required. For us, we believe that it's important to perform more studies in specific subgroups of patients to explore how potential risk modifier, such as age and sex, can affect the cardiovascular outcomes in patients with NAFLD. Thank you.
Thank you very much, Livnat, and congratulations for the presentation. I wanted to ask if there are questions by the committee and the professor Fedele. Please go to the computer. Thank you.
The pleasure for the work. I would like to know if there are some data about the hemodynamic profile of these patients, in order to better assess if there are hypotensive patients more than an defensive one. So, do you have some data?
Yeah, so we tried to extract as many data as possible. Whenever it was possible to extract hypertensive patients, glucose levels, hyperlipidemia, we extracted. However, we didn't have enough data to really have a significant analysis.
Just the curiosity, because you told them that at the beginning in the methods, that the cross-sectional studies were excluded. Cross-sectional studies were excluded, they were used as exclusion of the criteria. But in the results, you said that the type of study is an important predictor in meta-regression of the analysis. So my question is, in your meta-analysis, you included both cohort studies and case control studies? If the cohort study is a predictor, it means that in addition to cohort studies, there are other studies that were included in the
Yes, no, we did more, but this was the significant that we felt it was important to note. So we did include more.
Okay.
However.
Okay. Professor Cangemi, are you satisfied by the work of the candidates? Okay, thank you very much. Thank you very much, and congratulations. Now it's the time of the third candidate. The third candidate is Mia Jarden Revivo. The supervisor of Mia is Professor De Fedele, that will introduce the candidates in the thesis. The title of the thesis is COVID-19 cardiovascular disease and therapy. Please, Professor Fedele.
Dear colleagues, it's a very pleasure for me to introduce Mia Jarden Revivo. Is from Israel, and he cooperates very hardly with our group in the management of patients with COVID-19. As you know, we had a ward dedicated to patients with cardiovascular disease and COVID-19, and Mia Revivo helped us to collect data about these patients, as you will see, relative to the cardiovascular aspect and the cardiovascular therapy, in order to have data about their prognosis and their more precise management. Please present this data.
Thank you. Professor for the introduction. And thank you for the committee, and thank you for the audience, and especially can I do laser? So, as Professor Fedele said, my thesis is about COVID-19, cardiovascular disease, and therapy. So I would like to start with how and when COVID-19 affects the heart. We learned from global observation that COVID-19 can be progressed through 3 stages. Stage 1 is when we have viral replication. The patient will be asymptomatic and we will have 70% approximately from the patient will be recovered and we have no symptoms of COVID. However, 25% patient will progress into stage 2. In stage 2, we will have severe and it's localized. Okay. So we will, in stage 2, we will have more severe disease that is localized to the lungs. And this is the stage when we have the typical COVID-19 pneumonia and that we see on CT. 80% of patients will be able to be monitored at home and will have mild disease. However, 20% of patients will progress into stage 3. In stage 3, we will have severe immune response. We will have systemic inflammation, and this is the stage when we can see a cardiac complication and manifestation. The inflammation is characterized by elevated inflammatory markers such as D-dimer and ferritin, and we also have an increase in troponin. The percentage of mortality is about 2%, but this percent is increased with age and comorbidities. So in order for the virus to cause the inflammation, it must enter the cell. So COVID-19 enters the cell through ACE2 receptor, so it's the angiotensin converting enzyme 2. This receptor is found in various locations in the body, such as the lungs, heart, blood vessel, and the digestive system. Besides being the binding site for COVID, for the virus, it also plays a major role in the renin-angiotensin activating system. That is one of the most important systems in the body for regulation of blood pressure and inflammation, and is critical for the pathogenesis of hypertension and cardiovascular disease. So the exact mechanism of ACE2 in the renin-angiotensin activating system is by cleavage of the angiotensin 2 into angiotensin 1 and 7. Angiotensin 1 and 7 then bind mast receptor and will have pro-inflammatory effect on the body. This is contradict the effect of the angiotensin 1, as you can see, as you can see in the right side, and ACE and angiotensin 2 in the body, that they will lead to vascular permeability, inflammation, and fibrosis and vasoconstriction. So when COVID-19, when the virus enters the cell through the ACE2 receptor, it will cause downregulation of ACE2. The downregulation of ACE2 will lead to decreased activity of this enzyme, and this will lead to increase angiotensin 2, and this will have an inflammatory effect of the body. Furthermore, RAS inhibitors also have a role, also influence this system, and might have influence in the pathogenesis of COVID-19. We know that ACE inhibitors usually cause upregulation of ACE2 receptor, and this can increase the likelihood of infection by increasing the binding site for the COVID. However, I claim that angiotensin ACE inhibitor might reduce angiotensin 2, and this will lead maybe to a beneficial effect on the body. So I would like to know about the cardiovascular therapy and in COVID-19. So I spoke earlier about the RAS inhibitors, and the percent inhibitor influence COVID is still doubtful. However, there is no any data that supports any effect of RAS on COVID-19 patients. Other common beta blocker known to reduce viral entry by suppressing renin, They also know in the past to improve mortality in acute respiratory distress syndrome patients because they reduce the inflammation and they reduce interleukin-6. Also, we know that many beta blockers are common in cardiovascular patients, and stopping abruptly a beta blocker can lead to tachycardia and hypertension, and this can further worsen the prognosis of the patient. The last drug that I want to speak about is anticoagulants. Anticoagulants has been shown to decrease both mortality and complication of COVID-19. This is known because COVID-19, the virus can cause abnormalities, and this is seen as increased D-dimer in the body. So in order to understand the association between the cardiovascular therapy and the pre-existing complication on the prognosis of patients hospitalized for COVID-19, we conduct this study. So in this study, we evaluate clinical data from 229 patients, and they're all admitted to the cardiovascular disease COVID unit from November 2020 to May 2021. We collect data about pre-existing cardiovascular comorbidity, risk factor, and therapy that they received during the hospitalization. Also, we check the complication, if there are, and the prognostic factor, such as admission to the intensive care unit, and the outcome if they survive or not. So here you can see the baseline characteristic of our population. The mean age was 71. Female were less common, and at least 70% of patients had at least one cardiovascular risk comorbidity. The most common cardiovascular risk was 66.3% of patients. When we checked the pre-existing comorbidity, we found that the most common one was ischemic heart disease. It's 25% of patients approximately. After that, we had atrial fibrillation with 20% and heart failure with 60%. Here you can see the therapy that we checked, that the patient got. We checked beta blocker, RAS inhibitor, dexamethasone, and prophylactic heparin. Also, we check about the type of oxygen therapy that the patient got. And you can see that at least 76.8% of patients at least had one type of oxygen therapy. And when we check the prognosis, we noticed that almost half of the patients were admitted to the intensive care unit. And we had 10%, approximately 10% of patients who died. And this accounts for 22 of our total patients. When we check for COVID-19 complication during hospitalization, we saw that the complication was diverse. We had total 89 patients that had cardiac complication. From there, we found that 38.8 had cardiac complication, and the most common one was with 18.3% of patients. From the arrhythmia, we had atrial fibrillation as the most, at least half of the patients had arrhythmia. We had atrial fibrillation, and after that, we had acute coronary syndrome with almost 11. We also have heart failure with 3% of patients and pulmonary embolism with 5%. Cardiac inflammation was quite rare, and we had only 3 patients who had either pericarditis or myocarditis. So when we did statistical analysis of patients admitted to the intensive care unit or the cardiac intensive care unit, we found that at least one cardiovascular risk factor and the presence of ischemic heart disease, they are both influence that increase the admission of the patient to the intensive care unit. We saw that RAS inhibitor were not statistically significant influence the prognosis, and we saw also that beta blocker reduce the risk of being admitted to the intensive care unit. When we check about the statistical analysis about the complication of cardiovascular disease, we found that heart failure increased the risk of having complication. We found that heparin and dexamethasone and beta blocker are all reduced the risk. So in conclusion, in our study, we found that cardiovascular risk factor and cardiovascular disease are associated with increased COVID-19 severity, as we already know. Also, we know that ischemic heart disease was independently linked to greater severity of the disease. When we checked the complication, we found that heart failure increased the risk of having complication by 3. When we checked the drug, we found that RAS inhibitor do not impact disease severity, and beta blocker do decrease both complication and admission of the intensive care unit as we check as severity. Heparin dexamethasone also found to be reduced COVID-19 complication. Thank you.
Thank you very much, Note Mia, Note congratulations for your presentation. Are there any questions by the committee, Note Professor Midulla, Note then Professor Cangemi, and Professor Note Nicoletti? A lot of questions, Note Mia.
Thank you very much. Do you, in your opinion, do you think that is a direct effect of the virus on the muscles of the heart, or is it a consequence of the lung disease? Because the heart and the lung usually work together, and if you have a lung disease like an interstitial lung disease, you may have pulmonary hypertension, and the heart has to work more.
It's a good question. I think that directly to doubt, we didn't really see it, for example, in inflammation, but ACE2 receptor do found in the heart, and we saw that there is interaction between the downregulation and the activation of RAS. So I don't know if it's the lungs, but it's do the effect of RAS, for my opinion. That
Professor Cangemi.
That's a very interesting thesis. One question. Beta blockers were at the same dose they comes before, for example, for ischemic heart disease, or the dose was increased? Because is very, very interesting. The use of beta blocker to ameliorate, to avoid cardiovascular.
Correctly, we didn't measure the dose that was given. We just measured the presence that they would give during hospitalization, not before beta blocker. But if you ask about the dose, we just know that they received.
The last question is Professor Nicoletti, please.
First of all, my compliments for the presentation. I'm really glad that you and the previous 2 students have been so good in presenting your data. This is great. I noticed that one of the conclusions was that RAS inhibitors had no impact on the severity of the disease. However, you combine their ACE inhibitors and angiotensin receptor blockers. And my personal opinion, which of course is irrelevant, is that there is a big difference between these 2 classes of drugs during the pandemics. And the reason is that both drugs, they enhance the expression of ACE2, which is the receptor for the virus. But nevertheless, one of the drugs, the ACE inhibitor, will reduce angiotensin II levels. So it will reduce the competition between the virus and angiotensin II for ACE2. In contrast, angiotensin receptor blocker will increase angiotensin II levels, enhancing the competition, and also will block type 1 angiotensin receptor. So I think perhaps it's interesting to separate the patients with the 2 drugs, if this is possible.
It sounds great, but I completely agree with you. We presented to IFA one protocol that was stopped. I completely agree.
Please, Mia.
When I saw like the pathogenesis, exactly, you see that they were in different stages.
Yes.
So I also asked that, but in our study we combined.
Thank you very much. Okay, thank you very much, Note Mia, Note congratulations. And now there is the next Note candidate, Note is Georgios Antimiadis, the The title of the thesis of Giorgio is myocarditis associated necrotizing coronary vasculitis, incidence, cause, and outcome. The supervisor is the professor de Frustaci, but the candidate is presented and introduced by Professor Cristina Ticchinetti. Please, the professor introduce briefly the candidate and the thesis. Thank you.
Good afternoon to everybody. I have the pleasure to introduce Georgios Santiniadis. He performed a very interesting thesis on necrotizing coronary vasculitis in patients with myocarditis. And the candidate analyzed the incidence, the outcome, and the cause of this underestimated nosologic entity. He showed a very great interest in this topic and contribute in the analysis of data and the collection of clinical data. So, Georgios.
Thank you, Professor Minti, for your kind words for the introduction. A very good afternoon to the very good afternoon. A very good afternoon to the members of the graduation commission, to the students, to all the guests, and also to the people who watch us online. I would also like to express my heartfelt greetings and sincere thanks to Professor Andrea Frustaci for his guidance in the study, but unfortunately he cannot be here with us. So I would like to start my presentation with a brief description of myocarditis, which, as everybody knows, is an inflammatory process involving the myocardium. It's predominantly caused by viruses in Western countries, and and also can be caused by bacterial or fungal infections. It can also be caused by toxic substances and drugs, like, for example, the checkpoint inhibitors and the antipsychotics and antidepressant drugs. Finally, it can be caused also by systemic immune-mediated diseases. It's an important heart-specific inflammatory entity because it's associated with it can be associated with small abnormalities like in ECG, but can also cause severe outcomes like heart failure, arrhythmias, and sudden death. This is the reason why today the incidence and the prevalence of myocarditis is still difficult to estimate. This graph, this figure, I want to say that it shows us the graded heterogeneity regarding the death rate of myocarditis in the global map. As you can see, it's around 0.11 in countries like in Western countries, but it can be close to 6.7 death rate per 100,000 in countries like in Eastern Europe and Asia. The prognosis of myocarditis depends strongly on the underlying etiology of the disease, and rarely it can be associated with necrotizing coronary vasculitis to intramural vessels. When we start this project, we had two main objectives. The primary objectives of our study was to demonstrate that necrotizing coronary vasculitis is an under-recognized entity that may be associated to myocarditis. The secondary objective was to demonstrate that we would like to determine the incidence, the cause, and the outcome of this illness based on the underlying condition and its specific treatment. In our retrospective study that we done, we selected 1,116 patients with biopsy to myocarditis. Among them, we demonstrate that necrotizing coronary vasculitis was defined in 30 of them, which basically represent 1.5% of our study population. In all our patients today, we performed the myocardial biopsy, and all the samples were retrospectively studied with histology and immunohistochemistry, including myocardial expression of toll-like receptor 4, and we also performed a real-time PCR in order to determine the viral genomes in the cardiomyocytes. All our patients that was participating in this study, we performed in all of them a clinical assessment, baseline clinical assessment with resting electrocardiogram, Holter monitoring, and two-dimensional echocardiography. We followed our patients with two-dimensional echocardiography and cardiac magnetic resonance imaging, initially every week for the first 4 weeks, and afterwards we perform it every 4 weeks for the last 5 months. We also performed a cardiac catheterization and angiography, and also performed an endomyocardial biopsy in the end of our study, of course, after the informed consent of our patient. All our patients received a conventional medical treatment for heart failure and arrhythmias, but also the immunosuppressive treatment was used in case of virus-negative inflammatory cardiomyopathy, or in case of identification of an immunologic pathway, which basically is when we have when the analysis of our endomyocardial biopsy samples show that there's no viral genome in the sample, the toll-like receptor 4 are overexpressed, and we have a presence of anti-heart autoantibodies. Finally, we performed serum studies to our patient, in which we basically proceeded we look for anti-heart autoantibodies, and also for the inflammatory cytokine profile, and specifically the interleukin-1 beta, interleukin-6, interleukin-8, and tumor necrosis factor alpha. The results of our study basically show that the clinical manifestation of patients with myocarditis necrothoracic coronary vasculitis demonstrate that 26 out of 30 of our patients demonstrate a heart failure. We treated this patient with inotropic drugs, or in 11 of them, we used the mechanical circulatory support. 4 of them show presence of electrical instability. And regarding the immunological pattern of our study population, we demonstrate that the circulating levels of interleukin-1 beta, interleukin-8 are much higher in patients with myocarditis with necrothoracic coronary vasculitis in comparison with myocarditis patients and with the control group. Also, the presence of toll-like receptors 4 was overexpressed in patients with the myocarditis associated with necrothoracic coronary vasculitis in comparison with other 2 groups in patients without immune-mediated cause. Finally, the high sensitivity cardiac troponin levels were also overexpressed in patients with myocarditis and necrothoracic coronary vasculitis in comparison with the other groups. In this image, I would like to highlight the fact that, as you can see, the patients with myocarditis necrothoracic coronary vasculitis, we demonstrate the presence of extensive inflammatory infiltrates that presence both in cardiomyocytes, but also in the intramural vessels of our patients. As you can see on the right screen, on the right of the image, we also demonstrate that by performing indirect immunofluorescence, that patients with myocarditis necrothoracic coronary vasculitis have overexpressed toll-like receptors 4 in both cardiomyocytes, but also in the intramural vessels. In this image, the indirect immunofluorescence shows us one very interesting point, that the anti-heart autoantibodies was overexpressed in the cardiomyocytes, as was expected, but also it was overexpressed in the intramural vessels of our patients, which demonstrate the immune-mediated mechanism of this specific disease. Finally, very important result of our study was basically the comparison between the in-hospital mortality of this study population and with other two groups. And we demonstrated that the in-hospital mortality of patients with myocarditis, necrotitis, and vasculitis is much higher than in patients with myocarditis. And we're speaking about a percentage of 24 against 1.5% in the myocarditis cohort. Finally, I would like to conclude by saying that in this study, we demonstrate that necrotitis and chronic vasculitis is a rare entity that can be found histologically in up to 1.5% of patients with myocarditis. The necrotitis and chronic vasculitis can be caused, as we show in our study, by both viral and immune-mediated agents like autoimmune and autoreactive. Then hospital mortality was significantly higher, as I previously mentioned, in the myocarditis, necrotic vasculitis cohort in comparison with the myocarditis one. And an early identification of an immunologic pathway can be associated with a beneficial response to immunosuppressive therapy. Because as we perform our study, we demonstrate that 22 out of 25 patients that was treated with immunosuppressive treatment, the immunosuppression was successful. And none of our patients had any adverse effects, severe adverse effects that would cause the withdrawal of the treatment. Finally, I would like to say that our study and our team, we strongly recommend endomyocardial biopsy as a gold standard for diagnosis, for determining the diagnosis and the treatment of this population. And we demonstrate that by showing that the cardiac magnetic resonance cannot be compared with endomyocardial biopsy. I'd like to thank the members of the commission for their attention, and I would like to ask just 1 minute in order to thank Professor Fustacci and Professor Pimenti for the opportunity they gave me to participate in this project. I would like also to thank all the professors from the first year who tutored me and gave me this opportunity and guide me for all this medical career. And I also would like to thank my parents, Edward and Fatima Timiadis, for their sympathetic ear and the wise counsel, and also my wife for the constant encouragement she gave me. Thank you so much.
Professor Giordano, please.
First of all, congratulations, a very huge series of patients. Can you specify the time frame in which patients were collected first? And second, I want to ask you if a diagnosis of myocarditis was based on Dallas criteria histologically or was a clinical diagnosis? Thank you.
Thank you, Professor Giordano, for your question. So our study was based on, we used 5,180 samples of cardiac samples we had. It was basically from January 1983 until July of 2019. And in these 5,180 samples, we demonstrate the presence of myocarditis in 1,960 of them, 16 of them. We use histological Dallas criteria, as you said, in order to demonstrate the presence of myocarditis. And specifically, we also use the immunohistochemistry to make it even better, because as we know that the Dallas criteria is a good method to demonstrate the presence of myocarditis, but immunohistochemistry is even better method. And did I answer your question, Professor?
Okay. Okay, thank you Thank you very much, Giorgio. Congratulations for your presentation. Okay, now it's the time of Jasmine Beneyoun. The thesis of Jasmine is the title is Detection of Intestinal Antitransglutaminase of the two EGA deposits by double staining the immunohistochemistry, an adjunctive tool for celiac disease diagnosis in children. The supervisor of the thesis is Professor Carla Giordano. The thesis of the Professor Giordano introduced briefly on the candidate and the thesis.
Yes, it's my pleasure to introduce you Jasmine Benjalon. Actually, she performed this thesis collaborating in the setup of a new double immunohistochemistry method for an early marker of celiac disease. And then she validated this method on a pediatric series of patients. We believe that this method could be very important in assessing diagnosis in the so-called potential celiac disease that represent a group of patients that are clinically positive, show a borderline serology and negative histology. And she demonstrated great independence in the performing the studies, originality, and it was a very pleasure for me to work with her. So, Jasmine.
Thank you, Professor. Thank you, Professor, for your kind words. And I'd like to thank the Commission for giving me the opportunity to present our results, and to thank my friends and family who are always such a great support. So the main focus of this presentation is a new tool that could help in the diagnostic of celiac disease. Celiac disease is a systemic autoimmune disorder that is triggered by the ingestion of gluten in genetically susceptible individuals. It's an ubiquitous but manageable condition, thus the importance of diagnosis. Indeed, it's one of the most frequent autoimmune disorders. It leads to an increase of mortality and morbidity if left untreated, but it's manageable and it has an effective and safe treatment, which is lifelong gluten-free diet. Nowadays, the diagnosis is based on a multidisciplinary approach involving histology, genetic typing, and serology, with many autoantibodies identified, the most important of which is anti-transglutaminase IgA. In the specific case of children, a high titer positive serology may be sufficient for the diagnosis and avoid the invasive procedure. While in most of the cases, serology and conventional histology are adequate for the diagnosis of celiac disease, in some patients, the results of this test are equivocal, and we are facing the challenge of diagnosing the non-classical phenotypes without overdiagnosing the mimics. Here, I'm going to focus on potential celiac disease, which are the most relevant to our studies. And these are defined by positive serology and a normal mucosa without histological damage. This entity represents 1/5 of celiac disease patients, and it represents 1/5 of celiac disease patients, and the scientific community is still looking for a way to detect the evolution towards villus atrophy. So the autoantibodies anti-transglutaminase IgA, which are used for serology and for the screening of celiac disease, are produced by B lymphocytes in the intestinal mucosa. There, they create mucosal deposits before being secreted into the circulation. Recently, in several studies, these deposits have been demonstrated in celiac patients and in potential celiac disease. And such deposits seem to be able to predict an evolution towards villus atrophy and be an early marker of celiac disease. The detection by double immunofluorescence of these deposits is already set in many pathological laboratories, but it has important limitations as it requires fresh biopsy samples. The samples need to be stored and frozen at -80 degrees, and the signal decay over time. Thus, the need for a new cost-effective protocol that could be performed routinely. So the aims of our study are to validate this double staining immunohistochemistry for the detection of these deposits, to investigate the use of these deposits as diagnostic marker of potential celiac disease, and to improve diagnostic certainty in difficult cases. From a previously published cohort of 281 patients, we randomly enrolled 61 children, divided in
into the 4 following groups. So we have 2 groups with positive serology and histological damage compatible with celiac disease. The first group with a moderate level of transglutaminase, the second one with a low level, and the third group is potential celiac disease, so persistent positive serology with normal intestinal mucosa, and the last one is the controls with negative histology and serology. For the protocol, we rehydrated the sections from the duodenal biopsies. We incubated them first with anti-TG2 antibody that gives light brown signal, then with anti-IgA antibodies that gives red signal. Then we dehydrated and visualized results. On optic microscope, when we saw dark brown staining, that meant the colocalization of red signal and light brown signal, which is consistent with the presence of anti-TGA IgA deposits. The distribution of the deposits is defined as absent if we had no foci of dark brown staining, focal if we had less than 3 small foci alternated with negative areas, and multifocal or diffuse if we had more than 3 foci or a uniform dark brown staining. The question we wanted to answer are, is our protocol able to discriminate controls from patients with celiac disease? Is the distribution of the deposit different in the 4 groups identified? And what is the relationship between the level of atrophy and the distribution of deposits? So first, yes, our protocol highlights deposits in all untreated celiac patients, but never in controls. As you can see in the figure B, we can see a dark brown bundle at the level of the pseudoepithelium, while in the figure A, which is a control figure, we never see colocalization of red signal and light brown signal. Also, the distribution of the deposits in the bulk is significantly different in the 4 groups. In the moderate celiac disease, the distribution is mostly multifocal and diffused, while in the low positive, it's mostly focal. Interestingly, in 9 out of 14 potential celiac disease patients, we had deposits, and it was mostly focal deposits, and only 1 patient demonstrated multifocal diffuse deposits. Of course, in the controls, we never had any deposits. Also, it seems that a higher level of atrophy corresponds to more diffuse deposits. At the level of mucosal atrophy in overt celiac disease patients, the deposits were mostly multifocal, while in the normal mucosa, the deposits were mainly focal. Other results of interest is the clear dependence between the serum titer of the antibody and the presence of deposits in celiac patients. And this is in line with the hypothesis that this antibody is a spillover from the source compartment, which is the intestinal mucosa, into the blood compartment. Also, it seems that for the bulk, at lower level of IgA serum titer, we have a presence of deposits, which might be the sign of an earlier involvement of the bulk in the natural history of the celiac disease. Altogether, these results validate immunohistochemistry as a promising diagnostic tool, specifically for potential celiac disease. In comparison with immunofluorescence, it's cheaper and more widely available, and it gives the opportunity to reanalyze the sample. It could be used when facing challenging phenotypes of celiac disease, for example, potential celiac disease patients that could evolve into overt celiac disease, and that could be used to rule out mimics. It will improve clinical management by increasing the diagnostic yield, by identifying those in need of closer follow-up or early adoption of gluten-free diet, and preventing complications. So we suggest to perform double immunohistochemistry to evaluate mucosal deposits in all suspected celiac disease patients who underwent GI endoscopy and have been found negative for venous atrophy or other histological signs of celiac disease. Thank you for your attention.
Thank you very much, Yasmin. Are there not any questions by the committee? I have a question, Yasmin. Okay, so what do you think about, I mean, do you think that this technique is ready for implementation, that could be used in routine during the practice, or do you think that we need additional studies?
Actually, I think that we need additional studies to check for the cost effectiveness, to compare it with the gold standard. And also, because it's a pilot study, so we need it on a small cohort, so we need to validate it on more larger cohorts of patients.
Okay. Okay. Okay, thank you very much, Yasmin. I wanted to ask to Professor Giordano if you are formally satisfied. I feel satisfied. Okay, thank you very much. The next candidate is Beatrice De Passarani. Beatrice De Passarani is presenting a thesis. The title is COVID-19 and Health in Prison, a Critical Perspective. The supervisor of the thesis is Professor Marcheca. They will introduce briefly the candidates in the thesis. Thank you very much.
Thank you, President. Good afternoon, everyone. I'm happy to introduce briefly Beatrice. As you can see, her work is about COVID-19 and health in prison. But I'd like to stress that her interest on this theme was along the time of her course in medicine and surgery, when she was an active member of a medical students association, particularly for the dimension of health and human rights. This issue is very sensitive if we consider that just yesterday, the National Institute of Health has published a new report in the usual form of ad interim indication, which includes a specific part on this theme, obviously, particularly for the vaccination. Thank you.
Right. So thank you, Professor Marcheca, for the kind presentation, and good afternoon, everybody here and online. So I would like to begin with the health definition. As we know, all the pandemic mitigation strategies and lockdown prioritized a part of the population's health. Instead, with the cost of other health aspects, highlighting how the social field is important in determining the health status of the individuals. So that's why this research is focused on population already deprived of freedom, who may have been particularly vulnerable to the numerous health implications by the COVID-19 pandemic, and these for many reasons. At first, the SARS-CoV-2 can be transmitted very fastly via droplets, aerosols, but also contaminated surfaces, and environmental factors that contributes to its spreading are standing encounters with infected individuals, crowding, and indoor places that are not well ventilated. In this sense, prison populations results to be particularly at risk, also because health vulnerability of that population, so problematic drug use, mental health problems, and high prevalence of infectious diseases. And most of prisons, unfortunately, are characterized by the great problem of overcrowding. So this is the impact in prison in England and Wales, where most of prisoners are older than 60 years old and are males, whereas in USA, that 2.1 million of inmate population represents actually
a quarter of the total world inmate population. And that has been because of years of mass incarcerations to the down of Black, Latins, and indigenous population. In Italy, these are the data after 10,000 people, which you can see a higher contagion in prison than in the free population. So what can be done to manage this health burden in prison, pandemic burden in prison? You can manage to create more space for the internal management. So decreasing the input, increasing the output, and with an internal reorganization. So at first, to decrease the input, there can be a reduction in most severe crimes punishable only by imprisonment, as happened in 2020, in the first months for Italy, even though this was not so true for homicides against female gender, or direct condemnation of alternative sentences such as detention as decided by legislation. Then to increase the output, we have decarceration politics that were used by many countries, also in order to manage the great problem of overcrowding. And the principles for this were health issues, so frailty, and short-lasting sentences. So for the internal management, the decision was to close the prison environment to external people, but obviously not the working people. So to isolation, creating and using spaces for quarantine, trying to trace also people infectious contact. Then there is the use of personal protective equipment like personal hygiene, and in Italy the Istituto Superiore di Sanità, in collaboration with prison healthcare staff experts, did the guidance for prevention and control of COVID-19 in prisons, highlighting also the need for proper training of prison staff. Lastly, vaccination came in 2021. For this are the data by the Ministry of Justice, in which you can see the picture in March 8 and May 24. There is also a decreased number of COVID positive as the vaccination is increasing, but this is only a picture at that specific moment. So as Professor Marcega said previously, we had yesterday this document by the Istituto Superiore di Sanità, in which we have a vaccination against COVID-19 in the residential communities in Italy, priority and implementation modalities, in which we can see in a chapter about prison and how to implement the strategy, and also how to work on the so-called vaccination hesitancy. Coming back to 2020, fortunately, all these pandemic mitigation strategies, because of the social containment. So we had in Italy, in the first days of March, riots in which 14 inmates died. And so we can see that the tight lockdown and all this social containment had repercussion on rehabilitation and well-being. As we already know, the solitary confinement has been studied to worsen the psychological health of people, and we had in 2020 suicide rate higher than the last years, and that was 10 times higher in prison than in the free population. And also a number of critical events higher in prisons with less presence of psychologists and psychiatrists. Then there is also the interruption of school activities during lockdown that was very critical in a system in which the purpose is also to try to have a rehabilitation and a kind re-entry into the society. So to arrive at the conclusion, the COVID-19 exacerbated vulnerability of penitentiary institutions and prison systems have emerged as determinants of health, despite their continuous role in trying to rehabilitation in a pandemic in which pre-existing and poor health conditions worsened, and all these strategies debilitated social and psychological aspects. So we had a worsening of overall health condition. So to improve response and try to consider all the health aspects, there is the need for a sense of coordination between prisons and public health authorities, and the need for proper training by the prison staff to improve what is called the preparedness for critical situations. So this is my last slide. Thank you.
Thank you very much, Beatrice, and congratulations for your presentation. There are not any questions by the committee. I have another curiosity, Beatrice, because it seems to me that the percentage of vaccination among prisoners were a little bit higher than the percentage of vaccination among policemen and staff. It is correct or not? No?
Actually, is the opposite. Because we had at first more police personnel vaccinated, as it would be they go vector for infection, and then they decided to vaccinate.
Okay. Thank you very much, Beatrice. Thank you. Professor Marcega, are you satisfied formally or the kind? Thank you very much, Professor Marcega. Thank you. Okay, the next candidate is Senuri Dileka Ambawatta. Senuri Dileka Ambawatta is presenting the thesis. The title is The Impact of SARS-CoV-2 on Gastroenterology Outpatient Clinic Attendance, a comparative study between the time period prior to and during the initial lockdown in Rome, Italy. Professor Merli, the supervisor of the candidate.
Good afternoon to all the audience, and I have the pleasure to present Senuri. For me, she is Senuri, and she cooperates to this thesis with a lot of work, because unfortunately the hospital doesn't give you a data set elaborated, but you have to check all the data records and put it to make the comparison. So she was really clever in working also on Saturday and Sunday, because also the accessibility to the computer in the work is not so easy. And she will show you what was the difference during two periods, before COVID and during the first pandemic of COVID.
Thank you.
Thank you, Professor, and good afternoon, ladies and gentlemen. As we all know, the SARS-CoV pandemic has led to significant changes in healthcare systems around the world, and these changes have in turn given rise to new challenges when treating disease and managing disease. This is especially true for diseases, chronic diseases such as cirrhosis, which require constant, continuous interactions with the healthcare system for follow-up care. And so there has been the adoption of novel communication methods such as email use and telemedicine use in order to, this has been encouraged especially in outpatient settings. We conducted this study as a retrospective observational study by evaluating the patient records of a single gastroenterology outpatient clinic of Policlinico Umberto I, and by evaluating the emails sent to the clinic by cirrhotic patients during this time period. It was sent, these emails were sent to an email account that was dedicated especially to cirrhotic patients. The study period we took into account was the 3 months from September to November 2019 to represent the pre-pandemic period, and from March to May 2020 to represent the pandemic lockdown period. Our main objective here was to assess the changes in outpatient clinic attendance in general, and more specific objective was to observe the impact of disease severity and associated comorbidities on the clinic attendance of cirrhotic patients, either via email or in person. In order to do this, we use the pre-validated and most commonly used severity index, which is the MELD score, to assess severity, and the Charlson Comorbidity Index to assess comorbidities. It must be mentioned here that during the lockdown period in Rome, there was a reduction in outpatient patients seen as outpatients, and so most outpatient clinics were shut down. But this particular clinic chose to remain open and available for patients who wanted to present in person. And so we have this. We have a total of 247 patients presenting in person during the pre-pandemic period, and during the pandemic period, this was reduced to 96 patients. And if you look at the table, you see we also categorized the patients based on their main diagnosis, and we saw over a 50% decrease in attendance in every category. Here we see the overall trend in reduction of attendance during the 2 time periods, and we see a drastic reduction during especially during the first part of the lockdown. The gradual increase we see in attendance during the 3rd month is due to the easing of lockdown restrictions during the month of May in Rome. It must also be mentioned here that we did assess the age and sex of the patients attending this clinic, and there was a proportional decrease in all categories, and with most patients, with the majority of patients being male and falling into the 50 to 70 year age groups during both time periods. Speaking of cirrhotic patients in particular, we saw 58.8% decrease in attendance of cirrhotic patients overall, as we saw in a previous slide. However, we saw an increase in the percentage of decompensated patients attending the clinic during the pandemic time period. That is to say that during the pandemic, compared to the pre-pandemic time period, there were more patients as a percentage of the whole that presented to the clinic due to complications of cirrhosis. We also saw a decrease in the routine follow-up patients of about 20%. However, when we grouped the patients according to their MELD scores, we saw that there was not a significant difference in the number of patients attending with a higher MELD score. This could be due to the fact that patients with a MELD score of 15 or greater are usually eligible for liver transplant and are usually transferred to the liver transplant clinic. So when we look at the other 2 groups, we can say that overall the severity of patients attending the clinic during these 2 time periods was about the same. The Charlson Comorbidity Index assigns a score of 1 to 6 for 17 comorbidities as per their effect on mortality. We grouped these patients according to the original scoring system, the Charlson Comorbidity Index, and found only a slight increase in the number of patients with higher comorbidities who attended the clinic during the pandemic time period. So a majority of patients fell into the lower Charlson Comorbidity Index categories. The reason for this could be the nature of the index itself. Since the index gives higher scores for comorbidities such as HIV/AIDS and metastatic cancer, which is not so prevalent in this population of patients. It must also be mentioned here that Polyclinic Umberto I has a separate clinic for hepatocellular carcinoma, and so this could contribute to patients in this particular clinic falling into lower Charlson comorbidity index categories. We also assessed the reason for emailing. We also assessed the emails sent to this clinic by cirrhotic patients, and 63.5% of all the contact with the outpatient clinic during the pandemic period happened through the use of email. And while there was an increase in the use of emails of about 20%, the overall reasons for emailing remain much the same. However, we saw an increase of about 10% in patients sending analyses, and an increase in over 40% in patients asking for information during these uncertain times. Most concerning fact here might have been that patients during the pandemic period emailed due to the presence of new symptoms. However, since this number of patients is very small, this might not actually be all that significant. Here we see the overall trend in attendance of cirrhotic patients. In yellow, you see the number of patients sending emails over time, and in orange, you see the number of patients attending the clinic in person. And in gray, you see the number of patients who had sent emails during the pre-pandemic period, and you see the difference between the two time periods. So in conclusion, there was a drastic reduction of in-person outpatient visits, irrespective of age, sex, or main diagnosis. There was only a slight increase in patients attending due to patients who had higher comorbidities attending in person during the pandemic period. There was an increase of about 18% in the number of patients presenting with complications, and an increase in email use. While we expected the number of patients attending during the pandemic period to have higher severity, we found our data does not support this. The reason for this could be the fact that patients with higher severity, more severe disease, would be more afraid of coming into contact with COVID, and therefore they were more afraid of presenting to hospital settings. And this could be the reason why we have a higher number of emails. Further studies are needed to assess the impact of disease severity and associated comorbidities on outpatient clinic attendance. However, this study does show an important trend in increasing email use, which is supported by other studies where we have seen a surge of telemedicine use during the pandemic period. And this shows that the adoption of novel communication methods such as these is very important going forward, especially during this sort of time period where patients are either unable to or unwilling to present to outpatient or hospital settings. Thank you, and especially to Professor Murley for her unwavering support during the study.
Thank you very much, Odessa Nuri. Are there any congratulations for your presentation? Are there any questions by the Commission or the Professor Candemi or the please?
One thing. I know that you follow a patient with cirrhosis for cirrhosis for alcohol. You see for an increased use of alcohol or less attention to use medication in patients that didn't go to the visit directly, or they were well followed?
We didn't actually look into that sort of in-depth evaluation of each patient. We actually just looked at the overall picture.
hospitalization in gastroenterology of the department. And I repeat the name of the candidate, I'm sorry, Rawan Atem Mohamed Shendi Amer. The supervisor of the thesis is Professor Manuela Merli, and the professor to introduce briefly the candidate.
So it is a pleasure to present Rawan, and she will show us the other side of the coin, because Senuri mainly work on the outpatient clinic and Rawan mainly work on the department, on the patients which were hospitalized, and which were those usually more severe than those coming in the outpatient clinic. So please, Rawan, can you show your results? Thank you.
Thank you, Professor Merli. As Professor Merli mentioned, my topic is about the COVID impact on hospitalization in the gastroenterology department. I'll first briefly talk about the COVID's impact background. As most of us know, on January 30, 2020, the World Health Organization declared SARS coronavirus as a public health emergency of international concern. With Italy being the first Western country to sustain a substantial Italy's first wave started from February 21 and lasted till around May 4 when they gradually pulling down lockdown measures. As a response, the government implemented mitigation and containment strategies in order to contain the fast-growing pandemic and to handle the burden on the healthcare system. Here I'll dive on the different impacts of the departments in Italy. So in all departments, outpatient and freelance activities were either suspended or drastically marked down to urgency and oncological conditions. While in the maxillofacial and the gastroenterology department, you see that there is some medical staff allocations. While only in the gastroenterology departments, you see that some divisions had been utilized as COVID units, and some hospitals, as my colleague mentioned, employed telemedicine services as an alternative. While we also see there was a considerable reduction in all endoscopic activities, and that might be due to the risk of fecal contamination and airborne inhalation. There was also a similar reduction in the ultrasound application, and there was a cessation of colorectal cancer screening. The study also anticipates that such measures would have a potential ramification on the patient's clinical risk and the overwhelming management of the postponed procedures. So looking at the application of COVID, it's important because it will help in management of in the healthcare setting, and that's why the study's aim was to evaluate the difference in the quality and the quantity of hospital admissions in the gastroenterology department in by doing a 5-month retrospective observational study defining the pre-COVID interval from March to July 2019 and the COVID interval in the same period but in 2020. The variables examined were the age, the sex, the number and the length of hospitalization, the primary diagnosis at admission and discharge, the comorbidities, the ED triage, the MILF, and the CTP score in liver cirrhotic patients. What we observed in our study is that during the pre-COVID, there was a significant drop of hospitalization from 137, but there was one increase, so we study to 137 patients in the COVID period. The mean age and the male to female ratio were similar in both groups. However, the length of hospitalization was slightly but not significantly higher during the COVID period, and you can see that's especially in April and May. A possible explanation might be that during that time, resources were prioritized for COVID patients and thus delaying availability, which would mean a longer hospital stay. As we further down into the data, the main cause of admission during the COVID period was the programmed therapeutic interventions, such as chemomodulization of HCC lesions and esophageal ligation of varices. You can see that there was a 10% increase in the COVID period. However, in the flare-up as a cause of admission, there was a 10% reduction. The diagnostic workup remained similar in both groups. Although there was a difference in primary and follow-up, but it was not significant. So there was a drop during the COVID for the primary episodes and the increase in the follow-ups. Furthermore, the main diagnosis of admission during the COVID and the pre-COVID period was the primary malignant hepatic tumor. However, it was higher in the COVID period. And the second most common cause of admission was cirrhosis, accounting for more than 1/3 of the diagnoses at the COVID period, unlike only 17% in the pre-COVID period. And interestingly, it was non-alcoholic in the pre-COVID, while alcoholic in the COVID period. Looking at the severity pictures of the patients admitted, we see that during the COVID period, the comorbidity score was slightly, but significantly higher than the pre-COVID period, with a mean of 3. While, unlike the frailty picture, the ED triad was less severe in comparison during the COVID period, with a significant difference in the blue color. Further on, for the subset of liver cirrhotic patients, you find that there was a significant drop in the patients admitted with a MELD score greater than 15, and that would mean that it was a less severe picture. And we can say that a possible explanation is doctors and patients alike would have avoided exposing those subset of patients to the risk of acquiring COVID infection. And in addition to being polyclinic number to be at tertiary center, the transfer of indicated patients for liver transplant would have been avoided and compromised because of the risk of the general portion of COVID diffusion among hospitals. Despite what the previous studies mentioned, that there was a reduction in endoscopic utilization, and that's why we looked at that the endoscopic utilization, but during this study period, there were no significant differences. So in summary, looking at the patient's data during COVID, we observe an expected number of decrease in the number of hospitalization. And there was an average duration that tended to be longer in the first month. The demographic picture was unchanged, and the program therapeutic intervention was the main objective of hospitalization. The leading diagnosis was an oncological condition, and the patients tended to present with a higher number of comorbidities, but a lower triage evaluation, and that might be due to COVID changing the severity perception. Also, cirrhotic patients presented with a lower MELD, but a similar rate of decompensation as was seen by the CTD score. And the endoscopic utilization was not reduced in our university. So in an overall, you can say that there was a lower number during COVID. There was a lower number of patients admitted with a stable and a less severe clinical picture, but a higher number of comorbidities, unlike what you might have expected. Thank you.
Thank you, Anode, very much. Rawan, thank you very much. And congratulations, Anode, for your presentation. Are there any questions, Anode, by the professor of the committee? I have a question. I mean, this is, I like very much this kind of study, because this is a descriptive study, but I think that it's very informative. It is quite clear, I mean, that the impact of COVID-19 on hospitalization and in generally the use of the hospital is quite important. But I think that this is important also to realize the actual impact of decreased use of the hospital on the health of the population. In your I mean, in your opinion, which can be used as indicator of the actual impact on the health of the population?
Sorry,
For example, do you think that it is important to measure, for example, the mortality?
Yes, the number of when we looked at the study, we excluded those who were actually so we admitted all the patients who got admitted and then discharged. So it did not include the number of mortalities specifically in the gastroenterology department, but in general there was an all-excess mortality increase with an 85% difference during the COVID period than during the.
Okay, thank you. Professor Merlino, are you satisfied by the candidate? Yeah. Okay, thank you very much. So the next one, the candidate is Anna Zerich. Let me thank Anna because Anna is a class representative. So I think that we want to be very grateful to Anna because they made a lot of the works as a class representative. But in addition to that, the thesis of Anna Zerich, the title is Psychiatric Emergency in the Development of the Age, the Aftermath of COVID-19 the pandemic, as seen from the clinical front lines of Policlinico Umberto I, the hospital Rome. The supervisor of the thesis is Professor Fabio Midulla, who introduced briefly the candidate and the thesis. Thank you.
Good afternoon to everybody. I think that we all know what happened in our hospital during the COVID-19 pandemic. Overcrowded of the hospitals and in particular overcrowded of the emergency room. What happened with the pediatric department? It was exactly the opposite way. We performed a multi-center study with 15 hospitals and we showed that we had an 85% reduction in the number of patients that come to the pediatric emergency room in Italy, and mainly because of a drastic reduction of infectious disease, of communicable disease. But what happened with the fragile children? What happened with children with chronic disease? And this is what Anna will show today with a specific group of patients with psychological problems. It was really a pleasure to have Anna with us. We were very happy to have Anna in our department. She's a very smart student and a very pleasant person. Thank you very much.
Thank you very much for your very kind introduction, and I thank the whole commission and everyone here listening and watching. So before going into the details of the study, which will focus on psychiatric emergencies or mental health. So before going into the details of the study, which will focus on psychiatric emergencies or mental health emergencies, which is a very large spectrum of emergencies in developmental or pediatric age from 0 to 18, so from early childhood until late adolescence. Just to provide some very brief context about where does this study come from. So we weren't interested in further understanding what have been the direct implications of the outbreak of this new disease, COVID-19, for the pediatric population, because knowledge about this disease in pediatric age medically is already becoming increasingly consolidated. What we were interested in knowing is whether the events of the past January 2021, so the strict national lockdowns, specifically for this population, the prolonged school closures, and everything that now is grouped under this sort of new term, the pandemic-related stressors, how this has had indirect consequences on the pediatric population and in particular on their mental health. And lots has been said about this, especially found in the great literature. but the evidences, empirical evidences confirming these concerns about indirect consequences on the mental health are currently very sparse and very limited. So we decided to employ our clinical contact, our pediatric and general emergency departments, as a sort of early epidemiological observatory to identify changes, if any, that the pandemic period introduced in the frequency, both absolute and relative, and in the characteristics of child and adolescent mental health emergencies, looking at the demographic and clinical features of patients seen with this type of emergency, and looking at the severity of the initial presentation as indexed by hospitalization, and looking at how many of these patients had previously known, so were patients with a pre-existent mental health condition. And just so we all know what a psychiatric emergency is, it is an acute disturbance in thought, mood, or behavior that, whatever its background, it needs immediate therapeutic intervention, which is frequently a very complex care. And how did we achieve this objective? Through a retrospective cross-sectional design in two parts. In the first part, we examined 2 years of pediatric emergency department admissions for all types of emergencies, and then specifically for mental health emergencies, in a full year after the start of the national lockdown in Italy, March 9th, 2020, which was taken to be sort of the earliest date marking the start of the impact of the pandemic on Lazio region, because we were kind of the later ones to have the actual disease present. And then 12 months after this, until March 8th, 2021, and the preceding 12 months to have a pre-pandemic sort of a baseline control cohort, starting from March 9th, 2019. And this took all patients from 0 to 18 years old. And then we have a part 2. Why did we need a part 2? Because actually mental disorders have their peak age of onset in adolescence at age 14. And adolescence is in general an age of transition from pediatric to adult care. And so if we wanted to assess the impact of the pandemic on this population in its entirety, we needed to extend our data sources. And this is quite a complex process. So for the time being, it stopped at a briefer time interval. So we looked at all admissions to the pediatric and general emergency department starting from, again, March 9th, 2020, taking the 2 months of national lockdown until May 3rd, when it was lifted, the first national lockdown, and then taking the preceding 2 months in 2020 to have sort of a baseline. What was the situation in 2020 before the start of the lockdown for the adolescent admissions to our hospital? And then we took the same period from the prior year, again, for baseline comparison, so 4 months of 2019, and then the same period in 2021 to have a comparison of distant after effects, which is something that's really not known currently in the medical literature, and it's very recent. It stops until May 3rd, 2021. So what did we find? In part 1, we found that, as Professor Milula just said, there was a decrease in overall utilization of pediatric emergency department for all forms of emergencies. And as you can see in the table on your left, this goes down not only during the national lockdown period, but also in the early months of 2021. What happened with mental health emergencies instead, and here we look at this graph, and in red is the pandemic year, the 12 months of pandemic year, and in gray is the pre-pandemic year. If you observe the dotted line that follows the 12 months period, you will see that it's almost consistently above and even higher above the gray line, which means that mental health emergencies actually decreased in number in a lesser magnitude compared to other emergencies. And this is especially true for the periods in which restrictions were put in place. So if we see at the very left, at the early months, during the 2 months of lockdown, actually there is an increased relative frequency of mental health emergencies, but a lower absolute number. And this is again true in October, which you can see where there is a big gray peak. You see that actually the pandemic year saw a lower absolute number of patients. Instead, in the periods following the restrictions, as a sort of compensatory rise, we see physically more patients, so the absolute frequency increases. And this is true for the summer months of 2020, and it's very impressively true in the early months of 2021. So it is actually something that is happening now in the early months of 2021. And not only did the frequency distribution greatly change during the pandemic for this type of emergencies, but also the characteristics of the patients changed. So the patients belong now mostly to the age group of early adolescents from 10 to 14 years old, and less to the childhood group. So actually, it is almost as if children were protected in some way. And it is the early adolescents that were the ones that we saw the most. The numbers for late adolescents, as I said, are more informative in the second part of the study. This is only a minority of patients that we saw. The rates of hospitalization increased in the pandemic year. And most of the patients we saw, and more than the patients that we saw in the previous year, actually had already a pre-existing psychiatric diagnosis. And what else changed? The clinical categories. And this is quite an interesting finding, because if you see in the pre-pandemic year, conduct disorders and anxiety disorders were the sort of predominant conditions. And here you can see it, so the full line is the pandemic year and the dotted line is the full line is the pre-pandemic year and the dotted line is the pandemic year. If you see the peak in October that we saw earlier in 2019, is mainly due to anxiety disorders and conduct disorders. What happened in early 21, so the peak that we're seeing now, somatic symptom disorders increased, which is an internalizing condition, and the category others increased significantly to become the predominant one this year. And this category is labeled others because these are actually conditions not so frequently seen in pediatric age. They are very severe conditions. We're talking about depressive syndromes, we're talking about psychotic syndromes, and self-harm, suicidal attempts. And they are the ones that are increasing now. And bear in mind this result as we move to part 2, because what happened, so these are the results from part 2, in which if you look at the gray and the blue line, up until the start of the national lockdown, these are the first 2 months, they were quite comparable trends, both in absolute and relative numbers. The histogram shows the absolute numbers of patients per 2-week periods. What happened with the start of the national lockdown, once again, the number of adolescents seen for mental health emergencies decreased in a lesser amount than the overall large decrease of patients seen during the lockdown. And then again, the most striking findings is about 2021. Because what happened in 2021, which you see the red line, we have not only a marked increase in the relative frequency, but this is driven by a marked increase in the absolute frequency. So actually what happened is that in 2 weeks period, we saw up to 28, 26, 31 patients for mental health emergencies, something that didn't happen in the prior 2 years. So not only did we see many more patients, so 194 in the same period when 103 were seen, but there is a peak of 12 and 13 years old, bringing down the median age from 16 to 15. And there is a change in gender distribution with marked female predominance. Before it was quite even, the gender distribution, now it's 70% females. Many of the patients are returning patients, so they return multiple times during the 4 months period we examined. And this is called clinically the revolving door phenomenon, which means that the territorial care has an inadequate takeover of these patients. And the number of hospitalizations tripled, pointing to a higher severity of conditions. And this is because when we conducted the analysis of reasons for admission, what happened in 2021 is that the number of patients seen for disruptive impulse control and conduct disorder, which are all belonging to the externalizing spectrum, so which is damage to others instead of damage to self, they decreased, almost as if the pandemic year had some protective effect against these conditions. What increased dramatically is the self-harm spectrum of conditions. And these range from non-suicidal self-injury, which is already on the spectrum because it habituates the patient's pain, and it's really hard to put a line between suicidal intent and non-suicidal intent. Suicidal ideation increased dramatically, and suicidal attempts went from 11 to 29, bringing the overall number of self-harm patients from 32 in 2019 to 113 in the same 4 months in 2021. So what did we detect with this study? We detected the absolutely new evidence of ongoing neuropsychiatric emergency in the early months of 2021, with a homogeneous, largely increased population of adolescents, early adolescents the most, seen for mental health emergencies. They are younger, they are mostly female, and most of them present with severe self-harm manifestations. And when we went on, now I can't present these results, but when we went on to analyze the severe self-harm manifestations, we found that more of them were nuanced, more of them were severe types of self-harm. We had defenestrations for the first time. We had very severe methods of self-harm. And most of the patients belong to only 3 clinical categories, which were depressive disorders and personality disorders and eating disorders, marking a more homogeneous population than ever before. So while it's very complicated to understand why this is happening, there is multiple risk factors and protective factors at play, and we know that hospital statistics are just the point of the iceberg of a probably much larger community phenomenon. I think that this study already points to the fact that during the pandemic months, these patients, most of them with already psychiatric conditions, should have received more intense care, and their primary and territorial care and telemedicine should have cared for these patients more, because they shouldn't have ended with the emergency department, with an unspecialized emergency department becoming their safety net. And so now, today, the recovery post-pandemic should really focus on this identified vulnerable populations on every level. So from primary care to education, so we should promote reopening of schools. From primary and secondary prevention, emergency care, we should train pediatric physicians to care for these emergencies. And I believe this calls in all of society for a reflection, because really we're talking about modern generations and their lifelong health trajectory. So thank you very much for your attention.
Thank you very much, Anna, and congratulations for the presentation, and also for the study, and congratulations for the design, and also to Professor Midulla. I think that the study design is as elegant as you are, you know. Okay, Professor Tony, please.
Very interesting work, my compliments. Did you find any relationship with the social environment in the social, economic, or cultural level of the family?
So my data come from the anamnesis, the emergency analysis. So as much as I try to extrapolate as much as possible from that data, and I really did try to extrapolate as much as possible, I couldn't really find a way to examine that as well. So that's what I mean when I say that further studies are needed at community levels, because each and every one of these psychosocial risk factors should be examined one by one. And it's really hard to, I mean, what we're observing here is just the sort of end point of a number of heterogeneous upstream variables. And I think it's interesting to find this from an objective kind of endpoint, but many more studies are needed to understand why. Also because mental disorders were increasing already in the recent years in this age population. And so we might have just amplified that trend, but it's really hard to say.
Sorry, Claudio Tassinari Zugni Tauro. The title of the thesis on this mechanism underlying the early cognitive dysfunctions in mice models of spinocerebellar ataxia type 1. The supervisor is Professor Ferdinando Nicoletti, who introduced the candidate and the thesis. Thank you.
Thank you, President. Ladies and gentlemen, it is my privilege to introduce Claudio. Claudio is very bright, is nice, is extremely polite, and he works as neuromed in Posilli, Molise, which I think is a very nice place where you can work, because there is nothing else that you can do there. There is no sea in summertime, no snow in winter, no movie theaters. Actually, there is nothing, so you can only work. And however, the food is very good. There is an excellent mozzarella. It's better than in Campania, I should say. Sorry for that. And as Claudio knows very well. Now, yes, he knows. So jokes apart, Claudio has been very good, and all people in the lab like him a lot. And it will be a great pleasure to listen to you, Claudio. Please.
Thank you very much, Professor.
other professors, and everybody listening right now. Yes. And so as the professor was introducing, I'm talking about the spinocerebellar axis. It is a subset of the spinocerebellar axis, which are neurodegenerative disorders, which mainly manifest with motor symptoms due to the dysfunction of one of the symptoms we have, of course, ataxia, and dysphagia, dysarthria, also motor symptoms eventually will be. However, one disorder does not only involve the motor sphere, but it also enters into the cognitive sphere by showing, as we shall see right now, an early cognitive dysfunction due to hippocampal degeneration. The disease is quite rare. It has an age of development which is in 4 and has interesting pathophysiology, which involves a triplet expansion inside the ataxin-1 gene, the CHD triplet, which a gene that eventually codes the ataxin protein, which regulates the transcription and translation of many proteins, which we'll see, which are involved in intracellular. So our project aims at studying such early cognitive dysfunction, generation. We shall focus on the NF1 receptor, which is a receptor of glutamate that I will introduce in order to do so, use heterozygous not in our mice have been both at the Czech laboratories and have been bred in the Neural Institute itself. All the 8 weeks of age and will be treated, we shall see, 2 we have also performed immunohistochemistry analysis of many receptors which are expressed in the central nervous system of such mice, and we also underwent 3 different tests. We will see 2 for the motor symptomatology, 1 for the cognitive. The mGlu1 receptor, the somatotropic glutamate receptor, is expressed as a colleague at the neuron Serena Tomaso already proved. They're highly expressed in the cerebellum. However, their expression is very reduced, as you can see from the picture on the right. Such expression is reduced the cerebellum of SCA1 mice as compared to the counterpart wild type of normal mice. And the molecule itself is involved in the intracellular several pathways, which is called the glycerol inositol triple state, which eventually are involved into the mechanism of transmission. So we begin our investigation by first assessing the motor presymptomaticity of our mice. These mice do not show cerebellar atrophy, as seen by the staining of the finding, which is actually expressed by the protein cells in the cerebellum. There is no difference between the wild type and the SCA1 mice. Nor there is any decrease in the expression of the mGlu1 receptor in the cerebellum. In fact, if you test these mice, which our 2 means, you can see that there are no differences. The first test we have performed is the open field, which only includes, it only involves tracing the mouse inside an empty box in order to determine its motor behavior. As you can see, they move just as much as normal mice. And the rotor rod test. The rotor rod is a rotating rod which our mice are located, and the acceleration rod eventually leads to the fall of our mouse, and as you can see, the latency of the fall is completely equal between the wild type and the scour mice. Hence, we can say that our 8 weeks old mouse are completely asymptomatic under the model point of view. We then analyze the cognitive intent of mice, we do so by investigating factions. We have the water noise test. The test involves placing the mouse inside a pool full of water and having the mouse reach almost submerged platform, which is located in one part. As you can see from the bottom left image, the normal mice, which are the lower line, for each day of trial require always less time to reach such platform because they learn location. But the scour mice, they show no improvement at all in the reaching such platform. While on the bottom right, you can see there's a part of water test, which is a day in which the platform is removed. The mouse eventually will try to swim in the same quadrant where the platform used to be located. So a wild-type mouse spends most of the time inside such quadrant, while the scour mouse is unable to remember the location of the platform. Hence, it points towards its cognitive. We've analyzed again many receptors. The hippocampus of our mice. We perform again. Show again the source of the receptor. These are. You can see that there is a decrease in expression. Well, angle 5 and Homer 1 receptors, they tend to be. They do not show any significant difference. We proceed with the exploration of the energy receptors, again involving calcium signaling by the channel of the neuron. And again, we see a reduction in two subunits, which are the UN2A and UN2B, which bind the glutamate of the receptor. We see the decrease in expression, but a normal expression of the nuclear ones. So we test again the angle 1 receptor in order to analyze its pivotal role in the development of disease. We see again this time in our test we included the normal and scour mice, which are either treated or not with the RO. RO is the abbreviation for contact, which is a company. It's a positive allosteric regulator of the NP1 receptor. So it selectively activates the NP1 receptors, which are physiologically activated by the central nervous system itself. Selective. We see again the bottom lines of our water Morris test, showing that there is no increase in learning in the one type, and mice are treated not raw. However, the scour mice treated with such molecule, which is the middle line graph, show a significant reduction in time to reach the platform in the last days of the trial. While in our fifth trial, the mice treated with raw essentially show to spend more time in such a quadrant of our pool in which the platform used to be located. Again, showing that the scour mice treated with raw perform just as good as the one non-treated. In order to give a last to focus again on the M1 receptor, investigate its function, we have decided to block it. We do it with the J&J, with Johnson & Johnson, and which works in the opposite way. Negative monitor in one receptor, it blocks the one, And you can see in the graph that the wild type mice treated with GJ, which is the middle line in our graph, perform significantly worse, especially in the second and third day of trial, as compared with the wild type mice non-treated with the molecule. While our SCA1 mice, which are already lacking functional and one receptor, they do not show any worsening of the condition. SCA1 mice treated, it's super important with the line of non-treated mice, which is the last note is that there is no significant improvement or worsening of the memory test in either wild type and SCA1 mice. We can conclude analysis by saying that our 8 weeks old SCA1 mice are indeed pre-symptomatic, but only under the motor point of view, and they do show a decreased cognitive function, which is associated with the M1 receptor. If we activate such receptors, we can actually improve both learning and memory functions of mice. We keep them with the GJ, otherwise normal mice behave just as worse as the mentioned. Same M1 receptor agonist used by our colleague Serena Maso, proving that fully symptomatic SCA1 mice, 30 weeks old, show massive benefit by injection of the drug. The positive leaders can be considered best candidates for the treatment of spinal axis of one, which is a disease that has no treatment available.
Thank you very much, Claudio, and congratulations for your presentations. Are there any questions by the professor of the committee? Professor Nicoletti, any comment? Okay, so are you satisfied about the candidate? Thank you very much. Thank you very much, Claudio. Thank you very much. Konstantinos Avram is the next candidate. The title of the thesis is Associations between blood pressure parameters and the post-thrombectomy functional, procedural, and radiological outcomes. The supervisor of the thesis is Professor Danilo Toni, who introduce briefly the candidate of the thesis. Please, the Professor Toni.
Thank you, Mr. President. Good afternoon. It's a pleasure to introduce Konstantinos, who did a very good job on a crucial issue in acute stem cell treatment, which is, an ambivalence issue. Blood pressure in acute stroke must increase because perfusion pressure in the brain is the ratio between systemic pressure and intracranial pressure. After arterial occlusion, intracranial pressure increases, and hence systemic blood pressure must increase in order to keep perfusion pressure as adequate as possible. On the other hand, increase of blood pressure is a risk factor for complication, as for instance, hemorrhagic transformation of stroke or even brain edema. So what is the balance between the two different situations is difficult to say. On the other hand, the new, let's say, treatments for ischemic stroke, in particular, mechanical thrombectomy with a the possibility to reach a very early revascularization has completely changed the scenario. There are papers on the evaluation of relationship between post-procedural blood pressure and outcome, but there are no studies relating the dynamic course of blood pressure since the beginning, from hospital arrival through the procedure and up to the subsequent 24 hours of stroke onset. This is just the work that Costantino has done with a very constant activity and participation in our unit. And I'm very pleased to introduce him, and we will show you very interesting data. Costantino.
Thank you, Professor Tony, for the wonderful introduction. Before I start my presentation, I would like to thank Professor Tony and Dr. Bolini for their guidance throughout the conduction of the study. So, since 2015, mechanical thrombectomy has been established as a key treatment of acute ischemic stroke from large pressure occlusions. The role of blood pressure in these types of occlusions was controversial due to the fact that high blood pressure is fundamental for the ischemic penumbra survival, and also it increases the risk of secondary hemorrhages. Majority of previous studies have been focused on post-intervention of blood pressure and functional outcome of these patients, and also currently no studies have been conducted on the dynamic course of blood pressure from baseline through the procedure up to 24 hours after reperfusion. The objectives of the study was to see if there was any association of the blood pressure dynamic course within the first 24 hours in these type of patients with, first, functional outcome divided in good, bad, and excellent by the use of the modified ranking scale, which is a disability scale that ranges from 0 as no symptoms to 6 that is dead. Second of all, radiological outcomes such as hemorrhagic transformation, X classification, symptomatic intracranial hemorrhage, which is indicated by worsening of more than 4 points with the National Institute of Health stroke scale. And lastly, the reperfusional outcomes such as total number of passages and TC score, which is a score of reperfusion with grade 0 being no reperfusion and grade 3 being complete reperfusion. So we selected patients that came to Policlinico Alberto Primo from January 2015 until December 2020, and we included patients that had an occlusion in either anterior or posterior circulation. For each patient, we obtained their past history and also their clinical and radiological variables. In addition to these, we collected what type of anesthesia each patient underwent, and also if there was an administration of intravenous tissue plasminogen activator before mechanical thrombectomy. And finally, for the blood pressure, we started this registration at hospital admission. Then we continued at intraprocedural, at the interprocedural level at every 15 minutes throughout the procedure. And lastly, at post-interventional at the end of the procedure, 12, 18, and 24 hours. For the statistical analysis first, at the univariate analysis, we have here the mean values of systolic, diastolic, and mean blood pressure at pre-interventional, intraprocedural variants, and post-interventional levels, where we tested for the following variants: functional, radiological, and procedural outcomes. Afterwards, we performed a subgroup analysis where we had 2 subgroups, successful and unsuccessful recanalization, where we made comparison of their blood pressure and the functional and radiological outcomes. And lastly, we performed an ANOVA test where we obtained the repeated measures of systolic, diastolic, and mean blood pressure, and we compared their means with their association of functional outcome and recanalization. Firstly, in our results, we found that the multivariate analysis there was a statistical association between low pre-operative diastolic blood pressure and hemorrhagic transformation compared to the rest of the population. Second of all, when we performed a multivariate analysis of the repeated measures, we found that at high systolic and also high mean blood pressure, there was a statistical association with the worst functional outcome. This can be seen on the graphs on the right side of the slide, where the blue line indicates the worst functional outcomes. Same can be seen also on this graph underneath. And finally, when we perform multivariate analysis, where we consider both the repeated measurements of functional outcomes and successful recanalization, we found that there was a statistical association of the high mean blood pressures and worse functional outcomes. So for the conclusion of our study, we found that patients with good functional outcome had the lower systolic and mean blood pressure that was always ranging throughout the normal range throughout the whole analyzed period. Second of all, that better outcomes in patients with lower mean blood pressure was irrespective of their recanalization rates. We hypothesized that this is due to microvascular injuries. And lastly, that the low pre-procedural diastolic blood pressure is associated with the probability of hemorrhagic transformation. For this, we hypothesized that low preoperative blood pressure is associated with a decreased efficiency of collateral circulation, which is important for the maintenance of ischemic penumbra. Hence, in these patients, we have bigger ischemic lesions and increased probability of reperfusional injury. It can also be due to chance. Limitations of our study were that we had a small cohort of only 68 patients, that we included patients that underwent both types of anesthesia, whereas 68% out of them were under general one, and also the inclusion of patients that had an occlusion at both anterior and posterior circulation. The strengths of our study that were use systemic blood pressure measurements throughout the whole course, and we will recommend the conduction of randomized controlled studies for the identification of the cutoff systolic mean blood pressure, and also the formation of guidelines on the pre and post mechanical thrombectomy blood pressure management within the 24 hours. Lastly, I would like to end my presentation by thanking everyone for their attention. Thank you very much.
Thank you very much, De Constantinos, and congratulations for your presentation. Are there any questions? The Professor Fedele, please.
Congratulations for the study. I would like to know if the blood pressure was measured invasively or not invasively.
Thank you, Professor, for your question. No, we used non-invasive measurements throughout the process that we calculated the blood pressure since the administration also where the anesthesiologist was monitoring the blood pressure and reporting every 15 minutes as we said before.
Because the mean blood pressure not necessarily is not so accurate. Very good study.
Okay. Okay, so I have to ask formally to Professor Toni if you are satisfied about the candidates.
Yes.
Okay. Okay, so thank you very much, De Constantino. Okay, the first part of this session, the international part of this session is finished. At least the presentations of the candidates, and now the professor of the committee has to discuss a little bit your work and assign the final grades. So you can stay there, so they don't move from there. We the professor are going in another room in order to discuss a little bit your work, and then they were coming back, I think, in 5-10 minutes at maximum. Okay. Okay, I think that it's time to close this ceremony on with the assigning the formally the grades of this the final exam of the thesis. I will call each of you please when I call you come here and you will receive the professor of the Cangeni the Hippocratic Oath. Okay? So Beatrice De Passarani. Okay. Beatrice De Passarani, the commission has evaluated in a positive way your curriculum and also your thesis that was evaluated on the ground of the results and also on the way of your presentation. And the evaluation was positive. Therefore, by authority entrusted in me by the rector of Sapienza University of Rome, I declare you the doctor of medicine and surgery with the final grade of 105. Congratulations. Libnat Alon. Okay. Libnat, please, if you can, okay. Libnat Alon, the commission has evaluated your curriculum and also your thesis and taking into consideration the contents of your thesis and also the way that you presented the results to the commission and to the public. The evaluation was positive. Therefore, by authority entrusted in me by the rector of Sapienza University of Rome, I declare you the doctor of medicine and surgery with the final grade of 106. Congratulations. Konstantinos Avram. Konstantinos Avram, okay, Konstantinos, okay. Constantino Savram, the commission has evaluated in a positive way your curriculum and also your thesis, taking into consideration the contents of the results of your thesis and also the way that you presented the results to the commission and to the public. The evaluation was positive, therefore by authority entrusted in me by director of Sapienza at the University of Rome, I declare you the doctor in medicine and surgery with the final grade of 106. Congratulations. Sigal Noi Ladinsky. Sigal Noi, please look at the camera. Close on the two. Okay, please look at the camera over there. Okay, that's perfect, absolutely perfect. Sigal Noi Ladinsky, the commission has evaluated in a positive way your curriculum and your thesis. The evaluation was positive. Therefore, by authority entrusted in me by director of Sapienza at the University of Rome, I declare you the doctor in medicine and surgery with the final grade of 108. Congratulations. Rawan Adem Mohamed Shendi Amer. Amer, please come close to Professor Kangemi, look at the camera. That's perfect. Okay. Amer, Rawan Adem Mohamed Shendi, the commission has evaluated your curriculum and your thesis, taking into consideration your results and also the way of presentation of the results. The evaluation was positive. Therefore, by authority entrusted in me by director of Sapienza at the University of Rome, I declare you the doctor in medicine and surgery with the final grade of 110. Congratulations. Claudio Tassinari Zugni Tauro. Claudio Tassinari Zugni Tauro, the commission evaluated your curriculum. That's great. Your curriculum and your thesis. Your thesis was evaluated on the ground of the contents of your thesis and also the way that you presented the results to the commission and to the public. The evaluation was positive. Therefore, by authority entrusted in me by director of Sapienza at the University of Rome, I declare you the doctor in medicine and surgery with the final grade of 110. Congratulations. Senuri Dileka Ambawatta. Senuri, please look at the camera. That's okay. Senuri Dileka Ambawatta, the commission has evaluated your curriculum and your thesis, the contents and the results, and also the way that you presented the results of your thesis to the public and to the commission. The evaluation was positive. Therefore, by authority entrusted in me by director of Sapienza at the University of Rome, I declare you the doctor in medicine and surgery with the final grade of 110. Congratulations. Georgios Antimiadis. Georgios Antimiadis. Giorgio Antimiadis, please look at the camera. Okay. Giorgio Antimiadis, the commission has evaluated in a positive way your curriculum and your thesis. The results and also the way that you presented, those are the results to the commission. Therefore, by authority and entrusted in me, by director of Sapienza of the University of Rome, I declare you the doctor of medicine and surgery with the final grade of 110 with honor. Congratulations. Mia Yarden Revivo. Mia Yarden Revivo, the commission has evaluated your curriculum and your thesis, and the evaluation was positive. Therefore, by authority and entrusted in me, by director of Sapienza of the University of Rome, I declare you the doctor in medicine and surgery with the final grade of 110 with honor. Congratulations. Zerik, Ana Zerik. Ana Zerik, look at the camera. Okay, good. You are very good. Okay. Ana Zerik, the commission has evaluated your curriculum and your thesis. The thesis was evaluated both on the ground of the results and also of the way that you presented the results to the public and to the commission. The evaluation was very positive. Therefore, by authority and entrusted in me, by director of Sapienza of the University of Rome, I declare you the doctor of medicine and surgery with the final grade of 110 with honor. Congratulations. Yasmin de Beneyoun. Yasmin Beneyoun, the commission has evaluated your curriculum and your thesis, taking into consideration your results, the results of your work on the thesis, and also the way that you presented these results to the public and the commission. The evaluation was very positive. Therefore, by authority and entrusted in me, by director of Sapienza of the University of Rome, I declare you the doctor of medicine and surgery with the final grade of 110 with honor. Congratulations. I'm sorry, we have to read also the Hippocratic Oath. Okay. Now, the Yasmin de Beneyoun, on behalf of all of your candidates graduating now, is reading the Hippocratic Oath. I think that you have to stand up. And these are the reasons I remain here for some reasons of the technical. I want that you read, these are the Hippocratic Oath with, not the louding, but you read together with the Yasmin, okay?
I swear by Apollo the healer, Asclepius, Igea, and Panacea, and I take to witness all the gods and the goddess to keep, according to my ability and my judgment, the following oath and agreement. To consider dear to me as my parents, him who taught me this art, to live in common with him, and, if necessary, to share my goods with him. To look upon his children as my own brothers, to teach them his art. I will prescribe regimens for the good of my patients according to my ability and my judgment, and never to harm to anyone. I will not give a lethal drug to anyone if I am asked, nor will I advise such a plan. And similarly, I will not give a woman a pessary to cause an abortion. But I will preserve the purity of my life and my art. I will not cut or stone, even for patients in whom the disease is manifest. I will leave this operation to be performed by practitioners, specialists in these arts. In every house where I come, I will enter only for the good of my patients, keeping myself far from all intentional ill-doing and all seduction, and especially from the pleasures of love with men or with women, be they free or slaves. All that may come to my knowledge in the exercise of my profession or in the daily commerce with men, which ought not to spread abroad, I will keep secret and I will never reveal. If I keep this oath faithfully, may I enjoy my life and practice my art, respected by all men and in all times. But if I swerve from it or violate it, may the reverse may the reverse be my lot.
Remind that I'm the first person in your life that who are calling you doctors in an appropriate way. Please do not forget that it is for life. I'm the first person that are calling you doctors in an appropriate way. So, on behalf of all these the professors of this the committee, on behalf of all the professors of the International Medical School, I wish you the good luck for life. Congratulations. Senza nessuna soluzione di continuità, con una breve interruzione della pausa, insomma in diretta di streaming, noi diamo inizio alla seconda sessione. Dicono pausa biologica di 2 minuti, della peruta e poi riprendiamo, d'accordo? Buon pomeriggio, anzi buon pomeriggio, anzi buonasera, devo dire la verità a questo punto, a tutti quanti, è tempo di incominciare della seconda parte di questa sessione finale di tesi, della parte diciamo in italiano. Benvenuti, questo è un giorno importante, perché il giorno della vostra discussione finale di tesi. Io mi presento, te lo faccio anche per coloro che sostanzialmente, benissimo, coloro di quali sono collegati online. Io mi chiamo Paolo Villeri, sono professore di igiene e sanità pubblica e il preside del professor Carlo Della Rocca mi ha chiesto di sostituirlo nella presidenza di questa commissione finale di tesi. E io ovviamente sono molto felice di farlo. Un ringraziamento speciale a tutti i professori in pratica della commissione. Io penso che voi dei candidati vi dovete ritenere fortunati, perché avete la possibilità oggi pomeriggio, anzi stasera, di discutere dei risultati del vostro lavoro di tesi di fronte a una commissione che senz'altro è autorevole. Il giorno dell'esame finale di tesi è un giorno particolarmente importante, un giorno speciale, perché la conclusione di un lungo percorso, durante il quale avete lavorato tantissimo, per seguire delle lezioni, per preparare degli esami, per fare degli esami e anche per preparare il vostro lavoro finale di tesi. Proprio perché è un giorno speciale, richiede un'atmosfera particolare, va bene? È una sorta di cerimonia e dobbiamo mantenere un codice di comportamento appropriato sia all'interno di quest'aula, sia al di fuori dell'edificio, io direi sia anche al di fuori dell'università. La parola chiave in questi termini è sobrietà, e questo perché voi lo meritate, va bene? Perché è una cerimonia e come tutte le cerimonie ha bisogno sostanzialmente di una atmosfera appropriata e sobria. Questi mesi sono stati molto difficili per noi dei professori, ma anche per voi studenti. Voi sarete ricordati probabilmente come i laureati ai tempi del Covid-19, è giusto che sia così. Io penso che dobbiate essere orgogliosi di questo, perché io penso che alla fine di tutto questo, di tutti quanti noi, sia noi dei professori, sia voi studenti, oramai tra poco dei dottori, saremo un po' fortificati in pratica da questa esperienza. Io vi prego soprattutto di ricordare con orgoglio che voi tra poco sarete medici però laureati da Sapienza Università di Roma. Questa è una cosa di cui essere orgogliosi e non dovete dimenticarlo per tutta la vita. Io devo chiamare il primo candidato, però prima di chiamare il primo candidato, che faccio subito, consentitemi di ringraziare, oltre allo staff della presidenza, quindi al Domenico Della Peruta che ci sta curando in pratica anche della diretta streaming, consentitemi di ringraziare questi studenti borsisti, oggi sono due, ma come al solito sono veramente fantastici e devo dire la verità, ci stanno aiutando non soltanto per quanto riguarda questa tesi, ma per quanto riguarda tutta la gestione dell'attività didattica di questo periodo molto difficile. Per cui grazie mille a tutti e due, come al solito siete stati bravissimi. Ringrazio anche la dottoressa Renzi, ma la dottoressa Renzi che è una dottoranda del Dipartimento, la ringraziamo, del professor Marceco di tutti i giorni. Allora, io direi di chiamare il primo candidato. Il primo candidato è Federica Fruni. Federica Fruni presenta una tesi che si chiama Prevalenza di impatto prognostico della fibrillazione atriale in corso di sepsi, revisione sistematica e meta-analisi della letteratura. Il relatore della tesi è il professor Cangemi, che introduce brevemente la candidata alla tesi. Grazie.
Buonasera. Per me è veramente un onore presentare Federica, che anche lei in realtà ha lavorato con me negli ultimi anni, lavorando in particolare al rischio cardiovascolare, per esempio associato alle polmoniti, non Covid. Poi è arrivato il Covid e quindi si occupa di un'altra cosa, cioè ha iniziato a fare una meta-analisi sull'impatto e la prevalenza della fibrillazione atriale nei pazienti allargando quindi l'orizzonte non solo per le ma in generale nei pazienti. Lascio la parola a Federico.
Buonasera a tutti, ringrazio il professor Cangemi per la presentazione, il presidente di commissione e la commissione tutta. Il mio studio è una revisione sistematica, una meta-analisi della letteratura relativamente alla prevalenza e all'impatto prognostico della fibrillazione atriale in corso di sepsi. La fibrillazione atriale è una tachiaritmia sopraventricolare molto frequente, la cui incidenza e prevalenza risultano in aumento in relazione all'invecchiamento della popolazione mondiale e alla maggiore sopravvivenza con patologie croniche, interessando circa 1 su 3 individui. È una tachiaritmia caratterizzata da un'attività elettrica anomala e non coordinata che provoca l'inefficienza della contrazione atriale con conseguente riduzione del contributo di questa al riempimento ventricolare. Queste alterazioni, soprattutto in pazienti che di per sé presentano una funzione cardiaca già compromessa, possono determinare delle conseguenze anche molto gravi, come per esempio esacerbazione dello scompenso cardiaco, collasso emodinamico, oltre alla ridotta tolleranza all'esercizio fisico. Lo scenario entro cui abbiamo deciso di studiare la prevalenza e l'impatto prognostico della fibrillazione atriale è costituito da una popolazione di pazienti con sepsi, questa definita come disfunzione multiorgano causata da una risposta disregolata dell'organismo ad un'infezione, la quale può essere sostenuta sia da germi gram positivi che da germi gram negativi o da funghi e specie batteriche meno comuni nei pazienti immunocompromessi. Come precedentemente definito, la sepsi è appunto responsabile dell'innesco del danno multiorgano che può coinvolgere anche il cuore, le cui complicanze, come appunto l'insorgenza della fibrillazione atriale, sono associate ad un aumento significativo della mortalità in questi pazienti. E tra le cause responsabili del legame esistente tra queste due patologie si annoverano soprattutto l'infiammazione sistemica e lo stress ossidativo, i quali sono in grado di determinare la formazione di un substrato sia anatomico che elettrofisiologico per la fibrillazione atriale. In particolare, da diversi studi abbiamo notato che proprio l'aumento delle citokine circolanti, come il fattore di necrosi tumorale alfa, l'interleuchina 1, nonché la produzione di fattori cardiodepressivi, siano i principali protagonisti dell'innesco di questa cardiomiopatia settica. Infatti, le conseguenze dello stato iperinfiammatorio tipico della sepsi possono appunto ripercuotersi a livello cardiaco, determinando appunto un rimodellamento e una diminuzione della compliance ventricolare sinistra con conseguente allungamento e alterazione emodinamica a livello dell'atrio. Lo scopo del nostro studio è fornire una revisione sistematica e meta-analisi sulla prevalenza della fibrillazione atriale di nuova insorgenza in pazienti con sepsi e shock settico e di valutarne inoltre l'impatto prognostico in termini di mortalità sia intraospedaliera che in unità di terapia intensiva. Questa revisione sistematica è stata eseguita rispettando le linee guida e raccomandazioni PRISMA e abbiamo effettuato una ricerca completa della letteratura sui database PubMed ed Embase, utilizzando come parole chiave fibrillazione atriale, sepsi o batteriemia. I criteri di inclusione che vedete appunto riportati nella slide sono stati studi che riportavano la prevalenza di fibrillazione atriale di nuova insorgenza in pazienti con sepsi e studi che riportavano la mortalità intraospedaliera o in terapia intensiva in pazienti con sepsi e shock settico in base alla presenza della fibrillazione atriale di nuova insorgenza. Abbiamo invece deciso di escludere studi con meno di 50 pazienti con sepsi, abstract di conferenze, commenti, editoriali, case report, revisioni sistematiche e meta-analisi e articoli in una lingua diversa dall'inglese. Gli articoli che sono stati appunto ritrovati da questa ricerca sono stati sequenzialmente e sistematicamente esaminati da 2 autori in maniera individuale, considerando inizialmente titoli e abstract e secondariamente valutando l'idoneità del testo completo. Quando disponibile abbiamo raccolto anche i dati relativi alla numerosità campionaria, al numero di pazienti con fibrillazione atriale, alla localizzazione geografica dello studio, nonché anche alla tipologia dello studio stesso e anche ad eventuali comorbidità che abbiamo riscontrato essere presenti nei pazienti inclusi nello studio. Come appunto evidente nel flowchart, sono stati selezionati e quindi valutati per l'idoneità 111 sul TEX ed infine 21 studi sono stati inclusi nella nostra revisione sistematica per un totale di 207.599 pazienti con sepsi. Tra questi, la prevalenza aggregata di fibrillazione atriale di nuova insorgenza si è dimostrata essere del 14%, con un intervallo di confidenza compreso tra il 9 e il 21%. È stata però evidenziata tuttavia un'elevata eterogeneità tra gli studi. Per questo motivo abbiamo deciso di effettuare un'analisi di metaregressione, valutando diversi fattori che potessero in qualche modo spiegare e giustificare l'elevata variabilità riscontrata nella nostra meta-analisi. In particolare, all'analisi di metaregressione è emerso che gli studi condotti in Europa o Medio Oriente e studi la cui dimensione del campione includeva appunto meno di 100 pazienti sono significativamente associati ad un aumento della prevalenza di fibrillazione atriale nei pazienti con sepsi. Relativamente alla mortalità intraospedaliera invece abbiamo incluso 7 studi, mentre 4 hanno riportato la mortalità in unità di terapia intensiva. E da questi è emerso che nei pazienti con sepsi e con fibrillazione atriale di nuova insorgenza il rischio di mortalità intraospedaliera e in terapia intensiva aumenta rispettivamente di 2,3 e di 2,7 volte nei pazienti presentanti la fibrillazione atriale di nuova insorgenza rispetto appunto ai pazienti con una sepsi di gravità minore. Tuttavia, però, nella nostra meta-analisi abbiamo riscontrato diverse limitazioni, poiché in un numero significativo di studi i dati sul sottogruppo di pazienti con sepsi sono stati estratti da una popolazione generale con sovrapposte altre patologie critiche e questo fondamentalmente ha reso difficoltosa la raccolta di dati sulla gravità della sepsi, dunque sulla percentuale di pazienti con shock septico, limitando poi la possibilità di effettuare un'ulteriore analisi di sottogruppo, che probabilmente avrebbe spiegato appunto anche l'eterogeneità dello studio. Concludendo, però, abbiamo appurato che la fibrillazione atriale di insorgenza è una complicanza comune nei pazienti con sepsi, essendo presente in quasi un soggetto su 7 ed è associata inoltre ad un aumento del rischio di mortalità sia intraospedaliera che in terapia intensiva. Questo potrà permettere in futuro di effettuare ulteriori studi che a parer mio sono estremamente necessari per chiarire quale sia la migliore strategia di gestione e ovviamente di prevenzione degli eventi avversi nei pazienti con sepsi e fibrillazione atriale al fine di ridurre la mortalità associata alla concomitanza di queste due condizioni. Grazie per l'attenzione.
Molto bene, Note, grazie. Note. Ci sono domande? Grazie, Note, complimenti a Federica. Note. Ci sono domande Note, da parte Note, della Commissione? Per Federica? Quali sono gli ulteriori sviluppi? Note? Che cosa altro Note, dobbiamo fare Note, secondo te Note, per chiarire Note, questa associazione Note, tra fibrillazione Note, tra sepsi e fibrillazione atriale?
Grazie per la domanda. Diciamo che ad oggi c'è ancora un dibattito aperto relativamente proprio alla gestione di questi pazienti, sia relativamente alla possibilità di utilizzare un trattamento ambulante, così come relativamente alla prevenzione, quindi anche alla terapia di controllo ma infatti ad oggi fondamentalmente la gestione prevede un approccio su misura al paziente, che è considerato positivo, quindi considerato le comorbidità del paziente. Infatti a parere mio è fondamentale che vengano effettuati questi nuovi studi che consentono di cambiare, quindi di aggiornare le linee che ad oggi non risultano innovate alla stabilizzazione di questi pazienti.
Molto bene, Note, grazie. Note, devo chiedere Note, formalmente Note, al relatore, professor Cangelli, Note, se è soddisfatta Note, della candidata e del lavoro Note, stesso. Molto bene, Note, grazie mille e congratulazioni. Allora, la prossima Note, candidata Note, è Maria Chiara Note, Ferraro, Note, che si può Note, accomodare. Maria Chiara Note Ferraro Note, presenta Note, una tesi Note, che si chiama Studio di fase 1 Note, di cellule T geneticamente modificate, esprimenti il recettore chimerico antigenico, CAR, per CD19 in pazienti pediatrici affetti Note, da leucemia Note, linfoblastica acuta e linfomi non Hodgkin Note, B linfocitari ricidivati Note, refrattari. Il relatore Note, della tesi di Maria Chiara Note, Ferraro, del professore Note, Franco Note, Locatelli, che scusiamo tutti Note, perché Note, purtroppo Note, ha impegni Note, istituzionali, Note, mi ha pregato Note, in qualità Note, di presidente Note, della commissione di presentare Note, la candidata e lo faccio Note, con estremo Note, piacere. Note, si tratta Note, di uno studio di fase 1, sostanzialmente condotto su un certo determinato numero di pazienti, che ha avuto il compito di vedere sostanzialmente la sicurezza fondamentalmente di questa procedura, e anche sostanzialmente, se non sbaglio, di identificare bene quello che possono il migliore dosaggio di altri dettagli. Però Maria Chiara Ferraro ci spiegherà tutto in dettaglio. Te prego, Maria Chiara.
Grazie al Presidente per la presentazione, saluto tutta la Commissione e voi tutti qui presenti. La leucemia linfoblastica acuta è la neoplasia più frequente.
Maria Chiara, chiedo scusa, devi parlare più vicino al microfono così ti sentiamo benissimo. Ecco, benissimo, bravo.
La leucemia linfoblastica acuta è la neoplasia più frequente dell'età pediatrica, è una patologia clonale della cellula staminale mucoietica orientata in senso linfoide, che subisce un blocco maturativo e va incontro a una proliferazione anomala e incontrollata. A seconda del fenotipo di differenziazione della cellula staminale, essa può dare origine a una leucemia fenotipo T o fenotipo B. Quest'ultima è la forma più frequente e sarà l'oggetto della nostra discussione. Il motivo per cui ci siamo concentrati su questa patologia è innanzitutto la sua frequenza, come già detto, e in secondo luogo il fatto che, sebbene attualmente con i trattamenti standard si possa ottenere l'80% della guarigione, nel 20% dei casi i pazienti non rispondono alle terapie di prima linea e tra questi un 50-70% non risponde neppure ai trattamenti di seconda linea. Data quindi l'elevata incidenza di questa leucemia, è chiaro come questa percentuale costituisca un numero importante di pazienti. Ecco perché è fondamentale individuare nuove terapie di salvataggio e tra queste l'immunoterapia configura come una scelta particolarmente promettente, in quanto da un lato ha la potenzialità di curare questi pazienti e dall'altro permette di ridurre la tossicità dei trattamenti. Un obiettivo importante dal momento che parliamo di pazienti politrattati. La terapia con cellule CAR-T è una terapia estremamente innovativa che si basa sull'ingegnerizzazione dei linfociti autologhi del paziente. L'acronimo CAR sta per Chimeric Antigen Receptor. Questo ricettore è costituito da 3 componenti fuse tra loro, tra cui abbiamo un dominio trasmembrana connesso a una porzione extracellulare costituita dal frammento variabile a singola catena dell'anticorpo contro CD19. La scelta di questo target è stata secondaria al fatto che esso è espresso in maniera ubiquitaria su tutta la linea linfocitaria. La componente citoplasmatica è invece costituita dal dominio di attivazione CD3Z, proprio del TCR. Il costrutto appena descritto è di prima generazione e ha dimostrato una limitata capacità di attivazione. Ecco perché è stato implementato con l'aggiunta di una o due domini di costimolo a determinare un CAR di seconda o terza generazione. In particolare, nella leucemia ci siamo concentrati sul dominio 4-1BB che ha dimostrato la maggiore efficienza. Dunque, nel momento in cui una cellula T prende contatto con l'antigene, essa rilascia branchini e perforine che lisano la cellula target. Inoltre rilascia un numero importante di citochine e ciò può determinare quella che è la sindrome da rilascio di citochine, la forma di tossicità più frequentemente associata a questo farmaco. Vediamo brevemente come avviene la generazione di CAR di seconda generazione presso l'ospedale pediatrico Bambino Gesù di Roma. Il primo step consiste nella linfocitoferesi, ovvero il prelievo delle cellule mononucleate dal sangue del paziente. Esse vengono centrifugate al fine di separare i linfociti e vengono poi trasdotte con un gene contenente, con un vettore retrovirale contenente il gene codificante per il CAR e per la caspasi 9 inducibile. La caspasi 9 è un elemento fondamentale della catena apoptotica e in particolare questa forma inducibile è stata modificata con l'aggiunta di un dominio chiamato FKP12 che le consente di legare l'agente dimerizzante AB1903. Alla somministrazione di questo agente le cellule CAR-T vanno incontro ad apoptosi e ciò aumenta molto il profilo di sicurezza del farmaco. Gli obiettivi di questo studio di fase 1 saranno quindi valutare la fattibilità della produzione in ambito accademico delle cellule CAR-T, studiare il profilo di sicurezza al fine di determinare quella che è la dose raccomandata. Inoltre gli obiettivi secondari riguardano invece l'attivazione delle cellule CAR-T e in modo particolare la loro espansione e persistenza in circolo. Valuteremo anche in via preliminare quella che è l'efficacia di questo prodotto cellulare nei pazienti affetti da leucemia. Questo è uno studio di fase 1 per label che arruola 9 pazienti suddivisi in 3 coorti. A ciascuna coorte è stato attribuito un dosaggio di farmaco prestabilito secondo uno schema di escalation 3+3. A livello pratico, a tutti i pazienti è stata somministrata una chemioterapia linfodepletante della durata di 3 giorni, secondo lo schema evidenziato in questo cartoon. Seguono dei giorni di washout e al giorno 0 vi è l'infusione delle cellule CAR-T in singola somministrazione. In questa slide vediamo le caratteristiche dei pazienti, in particolar modo vorrei che ponesse l'attenzione sullo stato di malattia pre-infusione. Infatti tutti i nostri pazienti, prima di ricevere le cellule CAR-T, avevano sperimentato e fallito almeno 2 linee precedenti di terapia. Anche riguardo alla fattibilità mediana di protezione, da questa tabella vediamo come per tutti i pazienti è stata rispettata la dose terapeutica necessaria. Anche in merito alla vitalità e alla percentuale di cellule positive si sono rispettati i cut-off previsti, che erano rispettivamente dell'80% per la vitalità e del 20% per la percentuale di cellule CD3 positive. Non è stato quindi riscontrato il caso di primary immunodeficiency. Tutte le tossicità sono state monitorate per 4 settimane dall'infusione e per un periodo ulteriore laddove non si fossero completamente risolte. Le tossicità più frequenti sono state quella di carattere ematologico, presentata da tutti i pazienti come una citopenia lineare, e la plasia bicellulare dovuta al fatto che le cellule CAR-T sono dirette non solo verso le cellule tumorali, ma anche verso le cellule più sane. Altre tossicità sono state la sindrome da rilascio di citokine, manifestata in 6 pazienti in grado lieve, e l'aumento delle transaminasi, della bilirubina e alterazione degli elettroliti, tutti eventi autolimitanti. Nessuno dei nostri pazienti ha mostrato neurotossicità né tossicità limitanti la dose. È stato così possibile definire come dose raccomandata la dose massima prevista dal trial, pari a 3 milioni di cellule su chilogrammo di peso. Sotto il profilo clinico, l'attivazione delle cellule CAR-T si è mostrata con la presenza di febbre e con aumento degli indici di flogotia specifici attorno al giorno 3-4, con un picco alla settimana 2. Anche riguardo all'espansione delle cellule CAR-T in circolo, abbiamo avuto un picco alla seconda settimana. Inoltre questo dato si rispecchia nella riduzione di cellule CD19 in circolo, dovuta appunto all'attività intrinseca delle cellule CAR-T, e questo è un dato importante in quanto un marker che ci consente di valutare direttamente l'espansione e l'attivazione delle cellule CAR-T, e laddove la biselaplasia sia persa in modo precoce c'è un rischio maggiore di recidiva precoce. Un'analisi più approfondita delle sottopopolazioni linfocitarie mostra come nel momento di massima espansione si abbia avuto un aumento particolarmente importante delle cellule CD8, in quanto esse sono la componente più attiva e citotossica del nostro organismo. Sotto il piano della biodistribuzione abbiamo visto che le cellule CAR-T diffondono nel midollo osseo con un picco alla seconda settimana, e infine, anche se ciò esula degli obiettivi primari di una fase 1, abbiamo valutato via preliminare l'efficacia, dimostrando che la massima risposta sia a 4 settimane, con un tasso di emissioni complete pari all'87,5% dei pazienti affetti da leucemia. In conclusione, questo studio di fase 1 ha consentito di dimostrare che la generazione in ambito accademico di cellule CAR-T è fattibile. L'infusione è sicura dal momento che non sono state riscontrate tossicità limitanti la dose, ed è stato così possibile definire come dose raccomandata la dose massima prevista dal trial. Sotto il profilo dell'attività, le cellule CAR-T si espandono robustamente e biodistribuiscono a livello midollare. Per quanto riguarda l'efficacia, il prodotto cellulare ha dimostrato una buona capacità di controllo della malattia. Grazie dell'attenzione.
Molto bene, molto bene. Congratulazioni a Maria Chiara per la presentazione. Ci sono domande da parte dei commissari? Professor Marceca, te prego.
Non entro nel merito, mi è sembrato uno studio molto
Devi
rilevante.
entrare nel merito, ma soprattutto devi andare vicino al computer, perché ti devono inquadrare da casa.
Mi è sembrato molto elegante. Quello che però mi incuriosiva, non so se lei ha partecipato fin dall'inizio, è la dimensione bioetica. Stiamo parlando di bambini e mi chiedevo come è stata curata la comunicazione rispetto ai genitori per l'assenso a questi trattamenti sperimentali, perché non credo che sia facile comunicare a dei genitori tutte le possibili implicazioni di uno studio di fase 1 come questo.
I pazienti, come loro genitori, sono stati informati del trattamento a cui andavano incontro. Sottolineare il fatto che questo
penso che magari in modo appropriato
Grazie.
Che è Maria Sola, è una candidata, nota Maria Sola Fiumara. Maria Sola nota Fiumara, nota presenta una tesi nota che si chiama Implicazioni prognostiche nota della sarcopenia e della miosteatosi nella cirrosi epatica, studio prospettico multicentrico. La relatrice della professoressa nota Emanuela nota Merli, nota che introduce la candidata il lavoro di tesi. Prego.
Buonasera a tutti, mi fa piacere introdurre Maria Sola Fiumara che ha seguito negli ultimi 2 anni con noi uno studio multicentrico che è in via di conclusione ma non è ancora concluso, che ha permesso la raccolta di dati relativamente allo stato di carenza muscolare che avviene in questi pazienti precocemente rispetto alla sarcopenia dell'anziano e alla loro storia clinica che abbiamo coordinato appunto in questo periodo. E Maria Sole ci porterà un po' dei risultati che non sono conclusivi, ma intanto potuto analizzare.
Buonasera a tutti. Ringrazio la professoressa Merli per la presentazione. Il Presidente, mi metto ancora più dietro. Bene, ok. Ringrazio la professoressa Merli per la presentazione e saluto il Presidente di Commissione e la Commissione tutta. La sarcopenia è definita come depressione di massa muscolare associata alla perdita di forza e o di funzione del muscolo stesso, mentre invece la miosteatosi è data dalla deposizione ectopica di lipidi a livello intracitario. Queste entità sono state riscontrate primariamente nella popolazione geriatrica, per poi essere osservate anche nei pazienti affetti da malattia cronica, quale appunto è la cirrosi epatica. Inoltre sono state associate a numerose complicanze. In particolare la sarcopenia si associa al concetto di fragilità del paziente anziano, con un aumentato rischio di cadute, fratture e allentamento e le comorbidità associate a quest'ultimo. D'altra parte la miosteatosi, a causa dell'interferenza esercitata da alcune classi lipidiche sul pathway attivato dal recettore dell'insulina, è proprio stato identificato come un fattore di rischio per lo sviluppo di insulinoresistenza e diabete mellito di tipo 2. La sarcopenia nella cirrosi epatica prevede dei meccanismi in parte condivisi con il paziente anziano, tra i quali ricordiamo l'infiammazione sistemica e la malnutrizione, ma presenta anche dei tratti caratteristici di questa patologia, quali le modificazioni ormonali e l'iperammonemia. D'altra parte la miosteatosi presenta attualmente dei tratti ancora oscuri nella sua eziopatogenesi. Attualmente si pensa che alla base vi sia una disfunzione mitocondriale progressiva che comprometta la beta-ossidazione lipidica, determinando quindi un accumulo di questi lipidi non ossidati all'interno dei miociti. La sarcopenia e la miosteatosi sono stati inoltre oggetto di crescente interesse da parte della comunità scientifica, come possiamo osservare da questo grafico che riporta proprio il numero dei lavori pubblicati sull'argomento nel corso degli anni. Questi studi di tipo retrospettivo hanno identificato queste 2 entità come 2 fattori prognostici negativi nell'outcome del paziente cirrotico. Gli unici studi prospettici attualmente pubblicati sono stati svolti su popolazioni diverse da quella europea, quali appunto la nordamericana e la popolazione asiatica. Il nostro studio quindi si propone di valutare la prevalenza della sarcopenia e della miosteatosi nella popolazione cirrotica, di studiare l'impatto che esse hanno sulla mortalità dei pazienti e inoltre sul rischio di sviluppare le complicanze tipiche della cirrosi, sul numero di infezioni e di ospedalizzazioni in cui questi pazienti incorrono. Questo studio osservazionale di tipo prospettico multicentrico ha coinvolto 23 centri distribuiti lungo tutto il territorio nazionale, di cui il nostro centro, proprio il Policlinico Umberto I di Roma, ha rappresentato il centro coordinatore. Oggi vi presento i dati preliminari dello studio. In particolar modo abbiamo analizzato 368 pazienti al tempo zero, i quali sono stati valutati mediante la quantificazione delle diverse aree tessutali a livello della sezione trasversale compresa tra le 3 e le 4 della DC. Ciò ha permesso di identificare diversi indici, tra cui in particolare vediamo lo SMI, Skeletal Muscle Index, il quale è stato necessario per la diagnosi di sarcopenia. Questo è ottenuto normalizzando l'area muscolare totale espressa in centimetri quadrati per l'altezza del paziente espressa in metri ed elevata al quadrato. La stessa formula è stata poi applicata anche per gli indici relativi all'area totale del tessuto adiposo viscerale e sottocutaneo, dando luogo agli indici vati e stati. L'attenuazione del segnale muscolare misurata in Townsfield ha invece permesso la diagnosi di osteosi. Infine, sempre in questa fase preliminare, è stato effettuato anche un follow-up a 6 mesi su 255 pazienti, il quale ha analizzato diversi eventi avversi. L'analisi al tempo zero ha mostrato queste caratteristiche nella nostra popolazione. Osserviamo come il maggior numero di pazienti sia risultato di sesso maschile. L'età è stata, diciamo, compresa all'incirca tra 53 e 69 anni. I nostri pazienti variabilmente al momento dell'arruolamento presentavano le complicanze tipiche della cirrosi e le infezioni. La classe Child Pug maggiormente rappresentata è stata la B, mentre invece l'eziologia della cirrosi di più frequente riscontro è stata quella alcolica. Questi invece dati relativi alla sarcopenia e all'osteosi, osserviamo come il 40% del nostro campione abbia ricevuto diagnosi di sarcopenia, a fronte invece del 70% che ha ricevuto diagnosi di osteosi. Inoltre il 32% presentava contemporaneamente entrambe le condizioni. Mediante queste stesse metodiche è stato possibile valutare un'ulteriore entità, ossia l'obesità sarcopenica, anch'essa associata a una peggiore prognosi nei pazienti cirrotici, la quale attualmente è definita come la coesistenza di sarcopenia e di BMI superiore o uguale a 30 kg su metro quadro. Come possiamo osservare, solo 13 pazienti del nostro campione ha rispecchiato questa definizione. L'analisi al tempo zero ha anche previsto la comparazione delle diverse caratteristiche cliniche e demografiche tra i pazienti sarcopenici e non sarcopenici. Poniamo attenzione al maggior numero di pazienti sarcopenici aventi ascite e infezioni rispetto ai pazienti non sarcopenici. L'Engrip test, che è invece un metodo di valutazione della forza muscolare che si avvale dell'utilizzo del dinamometro, ha avuto risultati peggiori come atteso nei pazienti sarcopenici, così come anche il BMI, il quale ha avuto anche qui un valore minore proprio a causa della deplezione di massa muscolare e della malnutrizione di questi pazienti. I pazienti aventi osteosi, d'altra parte, presentavano un'età più avanzata e un punteggio MELD più elevato. Anche qui è stata riscontrata maggiore presenza di ascite e di infezioni e un Engrip test peggiore rispetto ai pazienti non aventi osteosi. L'analisi del follow-up a 6 mesi ha previsto la valutazione di questi diversi eventi. In particolare osserviamo come i pazienti sarcopenici siano andati più frequentemente incontro al trapianto di fegato rispetto ai pazienti non sarcopenici. D'altra parte, i pazienti aventi osteosi hanno presentato un numero maggiore di ospedalizzazioni rispetto ai pazienti non aventi questa condizione. Questa invece è la curva di Kaplan-Meier relativa alla sopravvivenza libera da trapianto nei pazienti sarcopenici, che è risultata peggiore rispetto ai pazienti non sarcopenici. Lo stesso è stato poi eseguito anche per i pazienti aventi osteosi, senza però riscontrare differenze significative con la popolazione non avente questa condizione. Per concludere, dunque, la sarcopenia e la osteosi si confermano prevalenti complicanze della cirrosi epatica. Inoltre, il follow-up a 6 mesi ha proprio messo in evidenza questa minore sopravvivenza libera da trapianto nei pazienti sarcopenici, mentre il dato relativo alle ospedalizzazioni è un dato da approfondire nel momento in cui lo studio avrà fine. Questo perché si tratta di pazienti che, come abbiamo osservato, presentano fattori confondenti, tra i quali appunto spiccano il punteggio medio più elevato e l'età più avanzata. Dunque, come abbiamo detto, si tratta di uno studio ancora in corso e questi sono solamente i dati preliminari. Il 9 luglio 2006 vincevamo i mondiali e mi sembrava giusto ricordare questo anniversario. Grazie per l'attenzione.
Io ho una curiosità. Prego, professor Canzelli.
Questa è una pura curiosità, è sicuramente molto anticipatoria, ma l'effetto di possibili terapie? Punto interrogativo?
Ora, ringrazio per la domanda innanzitutto. E per quanto riguarda le possibili terapie, queste sono state valutate soprattutto nell'ambito della sarcopenia. Innanzitutto ci sono state delle indicazioni per lo più nutrizionali, fino ad arrivare poi alle linee guida dell'ESPEN e dell'EAS, delle società europee riguardanti lo studio della malattia epatica e della nutrizione, che consigliano fondamentalmente di fare una dieta avente 30-50 kcal pro chilo al giorno, con almeno 1,5 grammi di proteine al giorno pro chilo. E tutto ciò poi ha portato in realtà anche a valutare come questi pazienti presentino soprattutto una riduzione degli amminoacidi a catena ramificata. Quindi si è pensato di implementare per via esogena questo tipo di amminoacidi e attualmente dagli ultimi review però sembra che non ci siano stati particolari effetti. Quindi attualmente sia la sarcopenia sia la mezzodosi non presentano una terapia, oltre alle indicazioni nutrizionali e appunto consiglio appunto di fare sport fondamentalmente.
Molto bene, devo chiedere alla relatrice, professoressa Merli, se si ritiene formalmente soddisfatta della candidata della tesi. Molto soddisfatta, per cui grazie a Maria Sola, a firmare, complimenti ancora. Grazie mille. Prossimo candidato è Davide De Narduzzi. Davide De Narduzzi presenta una tesi che si chiama Impatto del cambiamento degli stili di vita sulla relazione tra lockdown e insonnia, risultati di una survey sulla popolazione generale. Il relatore della tesi è il professor Loris Pagano. Prego, professor Pagano, voler introdurre brevemente il candidato e il contenuto della tesi.
Grazie Presidente, buonasera a tutti quanti. Entriamo nel territorio. Nel territorio in pieno lockdown abbiamo cercato di analizzare che cosa stava avvenendo. Abbiamo fatto un questionario molto grande nell'autunno del 2020, per cui quando avevamo passato tutto il momento più critico. Davide si è occupato di medicina preventiva, quindi siamo andati a vedere tra una patologia come l'insonnia e alcune modifiche di alcuni stili di vita che cosa stava succedendo in questo periodo di lockdown. Davide, a te la parola per illustrarci i risultati. Grazie.
Grazie professore per l'introduzione, buonasera Presidente. Il lockdown è una situazione eccezionale, è un impatto imprevedibile nella nostra vita. E questa è da solo una causa di stress che va a questo da solo è una causa di stress sia per l'effettiva comprensione del particolare momento storico e della gravità del momento storico, che per la frustrazione derivata dalle limitazioni che a volte si fa fatica. Questo stress può essere la base di diverse condizioni, una delle quali può essere appunto insonnia, un disturbo caratterizzato da una insufficiente quantità e qualità del sonno e una soggettiva sensazione di sonno non restauratore con una sempre soggettiva sensazione di malessere generale anche nella fase di è una patologia estremamente diffusa e con una prevalenza estremamente variabile a seconda delle aree del mondo che andiamo a considerare e degli studi che andiamo a considerare. Infatti possiamo vedere che lo studio Morfeo, che è uno dei principali che siano mai stati condotti in Italia in materia, arriva a quantificare la prevalenza fino al 64% degli intervistati. Ha un picco di incidenza comune entrambi i sessi dopo 65 anni, ne presenta un altro per 24-34 anni negli uomini e uno in coincidenza della menopausa nelle donne. Diceva anche il professore, abbiamo fatto un questionario e l'abbiamo trasmesso online tramite canali social e questo questionario appunto analizza un arco temporale che va dalla fase precedente al lockdown stesso. Hanno preso parte 1045 persone in forma anonima. Abbiamo raccolto dati anagrafici, informazioni su aspetti affettivi e cognitivi, stili di vita e stato psicofisico. Nel campione dello studio ci sono dei fattori che ci interessano in maniera particolare, che sono il sesso, l'età e infine lo status civile. Vedremo dopo perché. Gli outcome studiati sono il peggioramento dell'insonnia e l'insorgenza ex novo dell'insonnia, così come dichiarati dai pazienti non sulla base di diagnosi medica. A questo punto è importante ricordare che quelle che cerchiamo noi sono associazioni e non rapporti di causa-effetto. I fattori modificanti considerati sono il fumo di sigaretta, l'alcol, l'attività fisica e il cannabidiolo. E questi sono stati selezionati per via della loro forte presenza in letteratura e per l'utilizzo che spesso se ne fa come rimedi di automedicazione proprio per patologie come l'insonnia e lo stress. Dopodiché abbiamo fatto un'analisi di regressione logistica e in questa analisi di regressione logistica abbiamo considerato il contributo indipendente dei predittori che abbiamo appena detto e l'abbiamo corretto per i fattori confondenti che abbiamo nominato prima, quindi il sesso, l'età e lo status civile, e per un alfa, quindi una soglia di significatività settata a minore di 0,05, notiamo che per il primo outcome, quindi il peggioramento dell'insonnia, abbiamo un'associazione significativa fra alcol e attività fisica, con alcol e attività fisica, dove all'aumento del consumo di alcol corrisponde un peggioramento dei sintomi dell'insonnia, mentre a un aumento dell'attività fisica corrisponde un miglioramento, una inalterazione dei sintomi dell'insonnia. Quanto riguarda il secondo outcome, quindi l'insorgenza ex novo dell'insonnia, vediamo che l'associazione significativa questa volta è con sigarette e cannabidiolo, dove all'aumento del consumo di tabacco corrisponde un'aumentata insorgenza ex novo dell'insonnia, cosa che invece non accade con cannabidiolo. Una menzione particolare merita l'alcol, che pur non raggiungendo la soglia di significatività che ci eravamo preposti, mostra comunque un trend che lascia supporre una sua associazione all'insorgenza ex novo dell'insonnia. Arriviamo quindi alle conclusioni. Cosa ricaviamo da questi dati? Ricaviamo cose che possiamo già notare in letteratura, quindi che l'attività fisica è associata a un miglioramento dei sintomi dell'insonnia, se condotta nei modi e negli orari adeguati, quindi non troppo lontano né troppo a ridosso dell'addormentamento. E in letteratura notiamo anche che non è solo associata in maniera positiva al miglioramento dei sintomi dell'insonnia, ma anche quelli dello stress e quelli delle sindromi ansioso-depressive, che spesso sono alla base dell'insonnia. L'aumento del consumo di tabacco, quindi abbiamo detto che è associato negativamente all'insorgenza ex novo dell'insonnia, aumenta l'insorgenza ex novo dell'insonnia. Alcuni autori in letteratura hanno già notato questa cosa e associano l'azione cholinergica della nicotina a un'incrementata azione serotoninergica e dopaminergica che sembra avere un effetto disregolatorio sui circuiti che regolano il ciclo dell'origine. Quindi poi abbiamo alcol associato al peggioramento dei sintomi dell'insonnia. Anche qui c'è una disregolazione dei circuiti del ritmo sonno-veglia. Al contrario del sigaretta, che non ho detto, ma è associato maggiormente alla fase non REM, l'insonnia, nell'alcol è associato maggiormente alla fase REM. E abbiamo detto quindi c'è anche un trend negativo l'associazione con l'insorgenza. E non è tanto il consumo dell'alcol, che è notoriamente una sostanza sedativa, quanto la fase astinenziale che segue, che sembra mostrare l'associazione maggiore con l'insonnia, almeno questo dagli studi di letteratura, visto che la fase centrale del sonno è quella più coinvolta. Infine abbiamo l'associazione del cannabidiolo con una apparente proprietà nell'insorgenza dell'insonnia. Questo dato è da prendere con estrema cautela per l'esiguità delle risposte che abbiamo ottenuto e per il fatto che il questionario purtroppo non esplorava né le modalità di assunzione né le concentrazioni di CBD assunte dai soggetti che hanno risposto. Come ho già detto, le assunzioni sono statisticamente significative, sono in linea con quelle disponibili in letteratura. Come possiamo concludere? Possiamo dire che come ci aspettiamo già in altri disturbi che derivano dagli stili di vita scorretti, inadeguati, l'abolizione di questi stili di vita potrebbe essere una prima linea d'attacco. In particolare qua abbiamo sigarette e alcol. Nonché l'assunzione di stili di vita più corretti come l'attività fisica. Questa non è una novità, ma potrebbe essere un ulteriore incentivo alla prospettiva di un sonno migliore per convincere i pazienti a interrompere determinati stili di vita e prenderne altri. Per quanto riguarda il cannabidiolo, purtroppo per l'esiguità appunto delle risposte, per il fatto che in letteratura si trovano informazioni più su concentrazioni molto più elevate e con somministrazione nota, non dobbiamo lasciare uno studio. Io vi ringrazio per l'attenzione.
Grazie a Davide Narduzzi, complimenti per la presentazione. Ci sono domande per il Davide Narduzzi, da parte dei professori della commissione. Prego, professoressa Giordano.
Ho una curiosità, perché non avete valutato l'alimentazione o se ci sono studi che invece correlano con la...
Grazie per la domanda. In realtà l'alimentazione era stata esplorata dal questionario. Ho deciso io di lasciarlo a fuori e di prendere solo questi 4 predittori. È stata una mia scelta personale, il questionario in effetti la esplorava. E, effettivamente poi facendo ricerca in letteratura si trovano molte associazioni anche con gli orari e con il tipo di cibi che si vanno a ingerire, sulla durata della digestione, come questo modifica la capacità di addormentamento e la parte centrale del sonno. Effettivamente ho trovato molta letteratura, però a quel punto purtroppo avevo già deciso i predittori e solo questo.
Va bene, grazie a Davide Narduzzi. Professor Pagano, te devo ringraziare poi tra le altre cose per 2 motivi, perché il professor Pagano è qui in questa commissione, è presente in doppia veste, sia come membro della commissione del professore del corso di laurea, il relatore di tesi, ma è anche il rappresentante ufficiale dell'Ordine dei Medici di Roma, perché devo a tutti quanti ricordare, anche al pubblico, che i nostri laureati, semilaureati, non è detto, dobbiamo discutere, che i nostri laureati in realtà saranno immediatamente abilitati all'esercizio della professione senza bisogno dell'esame di Stato. Questo grazie al tirocinio abilitante che avete effettuato prima della laurea, sulla quale comunque si devono esprimere in sede di commissione finale di esame l'ordine dei provinciali, dei medici, dei chirurghi della provincia di Roma. E quindi il professore Pagano è presente in questa doppia veste. Però in qualità di relatore di Davide Narduzzi, ti devo chiedere come solitamente faccio, se ti puoi ritenere soddisfatto del candidato della tesi. Il professor Pagano dice sì, per cui grazie Davide, grazie mille, ancora complimenti. E arriviamo adesso all'ultima candidata di oggi, insomma, Chiara Tonarini. Chiara Tonarini presenta una tesi che si chiama il ruolo della ecografia polmonare nel follow-up del long covid pediatrico. Il relatore non potrebbe essere che il professore Fabio Midulla. Prego del professore di voler introdurre la candidata e il lavoro di tesi.
Allora, buonasera, ritorniamo a parlare di Covid pediatrico. Molto si conosce su quelli che sono gli effetti a distanza dell'infezione da SARS-CoV-2 negli adulti, che viene definito long Covid, e molto poco si sa di quello che potrebbe essere il long Covid pediatrico. Da febbraio 2021 noi abbiamo iniziato al Policlinico nel Dipartimento Materno Infantile e Scienze Urologiche un progetto di follow-up di tutti i bambini che hanno avuto il Covid, quindi l'infezione da SARS-CoV-2. È un follow-up epidemiologico, neurologico e allergologico. Chiara presenterà parte di questi risultati, presenterà in particolare quelli che potrebbero essere gli effetti a distanza respiratori, utilizzando una tecnica che è l'ecografia polmonare, che è una tecnica non invasiva che ti può dare molte informazioni su quello che è il parenchima, la patologia del parenchima polmonare. È stato un piacere avere Chiara in questi anni con noi, ha partecipato attivamente nella raccolta e nell'analisi dei dati e si è integrata molto bene con tutto il nostro gruppo, quindi ti ringrazio per quello che hai fatto.
Ringrazio il professor Midulla per l'introduzione e la commissione tutta. Questo studio appunto riguarda il ruolo dell'ecografia polmonare nel follow-up del long covid pediatrico. Dal marzo 2020, quando l'OMS ha dichiarato la pandemia causata dal nuovo coronavirus SARS-CoV-2 al Situation Report del luglio 2021, sono stati registrati oltre 183 milioni di casi nel mondo, con quasi 4 milioni di decessi. E contrariamente a ciò che si pensava inizialmente, il Covid-19 colpisce purtroppo anche la popolazione pediatrica. La caratteristica della popolazione pediatrica è proprio il fatto che l'infezione risulti essere più mild, quindi più lieve rispetto a quella degli adulti, estrinsecandosi diciamo in forma di solito asintomatica o quasi sintomatica. Quando parliamo di long covid facciamo riferimento a quello spettro di manifestazioni cliniche che permangono a lungo termine anche dopo la fase di risoluzione dell'infezione stessa, motivo per cui abbiamo reputato opportuno indagare proprio quest'ambito. Il nostro studio riguarda una metodica, in particolare l'ecografia polmonare, utilizzata per valutare il grado di coinvolgimento del parenchima polmonare durante questa infezione. L'ecografia polmonare, come ha anticipato il professor Midulla, è una metodica appunto estremamente rapida, di facile reperibilità e che non espone i piccoli pazienti a radiazioni ionizzanti. La caratteristica rispetto ad altre metodiche come l'RX e la TAC è il fatto che fornisce delle immagini anatomiche solamente per ciò che si trova al di sopra della linea pleurica, che qui nella tabella vediamo come questa linea iperecogena. Tutto ciò che si trova al di sotto è rappresentato da degli artefatti fisiologici che sono normalmente presenti nel polmone normale. Nella patologia interstiziale, quindi nell'infezione da SARS-CoV-2, possiamo far riferimento al fatto che scompaiono questi artefatti fisiologici comparendo degli artefatti patologici. L'ecografia polmonare, vediamo appunto nella tabella come abbia un'elevata concordanza con l'RX torace, ampiamente utilizzata nei pronto soccorsi, e con la TAC polmonare, che è il gold standard appunto nella diagnosi nella polmonite da Covid-19, sia nella fase, quindi questa concordanza sia nella fase diagnostica che poi nella fase di monitoraggio clinico clinico ed evolutiva appunto dell'infezione. Quindi da qui gli obiettivi del nostro studio sono stati innanzitutto valutare proprio la presenza di questi artefatti ecografici patologici nei pazienti con pregressa infezione da SARS-CoV-2 e secondariamente associare appunto i risultati ecografici sulla base di quelle che sono le differenze epidemiologiche della popolazione che abbiamo considerato e del tempo soprattutto trascorso dall'infezione. Quindi abbiamo arruolato 286 pazienti, 143 maschi e 143 femmine al Policlinico Umberto I nei mesi compresi fra febbraio e maggio 2021. I pazienti considerati avevano un'età compresa fra gli 0 e i 18 anni e avevano tutti almeno la data del primo tampone molecolare positivo. La metodica, l'ecografia polmonare, è stata eseguita suddividendo il torace in 12 quadranti, 8 anteriori e 4 posteriori, e facendo scorrere la sonda lineare lungo delle linee longitudinali parallele sul torace, con il paziente in posizione supina e seduta, procedendo dagli apici verso le basi, secondo un'analisi a step successivi. Ciò che è emerso e quello che abbiamo analizzato, queste sono delle immagini che sono state appunto repertate proprio a livello della radiologia della clinica pediatrica. Abbiamo identificato 5 differenti pattern riguardanti il parenchima polmonare a seconda della riduzione del grado di areazione di questo. Il pattern A1 in particolare possiamo identificarlo come il polmone sano, quindi vediamo questa linea pleurica regolare che è la linea iperecogena che distinguiamo bene nella prima immagine in alto, assenza di altri artefatti. Per quanto riguarda il pattern A2, il primo vero pattern patologico, caratterizzato semplicemente da un'irregolarità della linea pleurica che è stata considerata irregolare ogni qualvolta si fosse manifestata granulare, ondulata o ispessita. Il pattern B1 invece è caratterizzato dalla presenza di artefatti che sono definiti linee B, in particolare qui linee B multifocali, come vediamo nell'immagine di sinistra, che sono appunto queste strie perecogene perpendicolari alla linea pleurica che si approdano nel parenchima polmonare, oppure la presenza di addensamenti, queste aree disventilatorie a livello subpleurico che possiamo identificare nell'immagine di destra invece, del diametro maggiore inferiore a 0,5 cm. Il pattern B2 con sempre linee B, ma questa volta confluenti, quindi vediamo nell'immagine di sinistra compattate fra di loro, e oppure la presenza di addensamenti con un diametro maggiore rispetto al pattern B1, quindi compreso tra 0,5 e 1 cm. Il pattern C invece addensamenti con un diametro maggiore di 1 centimetro fino poi alla completa epatizzazione del polmone, però c'è da dire che questo pattern non è stato riscontrato in nessuno dei pazienti da noi esaminati. Veniamo ai risultati. Dunque, innanzitutto analizzando le frequenze, quello che si può evincere dal grafico è che quasi la metà dei pazienti aveva almeno un'alterazione a livello del parenchima polmonare, il 46,8%. E un'altra considerazione che si può fare è che le frequenze risultano inversamente proporzionali alla gravità dell'alterazione ecografica identificata e poi del rispettivo pattern. Dopodiché che cosa abbiamo fatto? Abbiamo analizzato i risultati e li abbiamo confrontati con la popolazione da noi considerata, e quindi quello che si può evincere da questo grafico, dove abbiamo analizzato in particolar modo i sintomi del paziente, considerando pazienti asintomatici che vediamo nelle colonne in verde, con sintomi aspecifici, cioè sintomi di qualsiasi tipo, o nelle colonne invece in rosa, pazienti con sintomatologia respiratoria. Da questo grafico si evince il fatto che nei pazienti asintomatici le frequenze di ogni pattern risultavano essere drasticamente inferiori rispetto ai pazienti con sintomi aspecifici o con sintomi respiratori. Quello che però risulta essere dirimente nella nostra indagine è sicuramente il tempo trascorso dall'infezione. In particolare vediamo come le frequenze di ogni pattern, ed in particolare il pattern A2 avvalorato poi dalla significatività statistica, risultino essere molto più elevate nei pazienti che avevano avuto l'infezione da un tempo inferiore di 6 mesi rispetto a quelli che avevano avuto l'infezione da un tempo maggiore di 6 mesi. Quindi sostanzialmente quello che possiamo dire è che l'ecografia polmonare nei pazienti con pregresso Covid-19 ha evidenziato la presenza di artefatti patologici. Questi però sono artefatti aspecifici e di varia entità, che non sempre risultano legati a caratteristiche clinico-epidemiologiche, perché poi effettivamente abbiamo anche analizzato se ci fossero delle correlazioni tra il sesso maschile e il sesso femminile, oppure pregressa storia di bronchite asmatica, bronchiolite, senza insomma ottenere dei risultati significativi. Con le attuali conoscenze non possiamo dire con certezza se questi reperti siano effettivamente associati all'infezione. Questo probabilmente però perché non possediamo una popolazione sana di controllo. Quello che si può dire è che la correlazione effettivamente emersa con il fattore temporale ci suggerisce la necessità di indagare l'evoluzione del quadro polmonare tramite un follow-up seriato per valutare se questi pattern e queste alterazioni ecografiche a livello polmonare possano effettivamente andare incontro a regressioni, oppure se si dovessero manifestare una permanenza di queste a lungo termine. Grazie per l'attenzione.
Molto bene, grazie, Chiara, Tomarini, complimenti per la presentazione, ci sono domande da parte dei professori, commissari. Io ho apprezzato molto della presentazione della tesi, devo dire la verità, perché mi sembra, nonostante il professor Midulla, mi sembrano estremamente rigorose, anche per quanto riguarda, in realtà insomma è uno scherzo, ti sto facendo i complimenti, perché sei stata molto attenta, hai specificato del fatto che non è possibile stabilire una correlazione perché non c'è un gruppo di controllo, impeccabile, devo dire la verità, anche se le evidenze scientifiche della tua tesi in realtà ci fanno pensare molto a questa cosa qua. E poi mi è piaciuto molto il fatto che chiaramente quello che è indicato è sostanzialmente uno studio longitudinale, prospettico, di maniera tale da fare ecografie ripetute, per cui presumono che questa...
È uno studio molto semplice, perché non hanno fatto per fare l'eco a dei bambini che hanno Covid. Non saremmo aspettati dei risultati comprensivi, perché erano tanti quando noi abbiamo fatto l'esame erano negativi, e assicurato invece in realtà questo è fuori che quasi il 40% di questi bambini hanno che artefatti, che poi diminuiscono con il passare del tempo, quindi alla fine stiamo pensando che effettivamente sono una infezione.
Certo.
Questo virus alla fine anche nei bambini, se guardate una tecnologia più importante, anche motivato.
Assolutamente. E poi non so se in età pediatrica, però oramai si dice che il long covid sarà uno dei principali problemi che dovremmo affrontare nei prossimi anni, sia dal punto di vista dell'assistenza, sia anche dal punto di vista di capire sostanzialmente effettivamente che cosa c'è dietro. Molto bene, allora grazie mille e complimenti ancora, molto bene. Allora, abbiamo terminato la discussione dei nostri candidati, i nostri candidati rimangono qui in aula, siamo noi dei commissari, che ci riuniamo per un attimo in maniera tale da discutere un pochettino e da stabilire i vostri voti finali. Ritorneremo tra un massimo di 5 minuti, va bene? Allora, siamo arrivati al momento finale di questa sessione finale di tesi. Chiamerò i candidati a uno, che sono pregati di avvicinarsi alla cattedra. Io assegnerò sostanzialmente il voto che è stabilito della commissione, del professor Cangemi consegnerà a ciascuno di voi il giuramento di Ippocrate. Davide Narduzzi. Davide Narduzzi, guardano della telecamera, della commissione ha valutato in maniera positiva della tua, sia del tuo curriculum, quindi la media curricolare e quant'altro, della tesi, sia dal punto di vista dei contenuti che dal punto di vista della presentazione. Pertanto, per i poteri a me conferiti dalla legge, per delega specifica della magnifica rettrice di Sapienza, Università di Roma, la dichiaro, la proclamo del dottore di medicina e chirurgia con la votazione finale di 100 su 110. Congratulazioni. Maria Sola Fiumara. Maria Sola Fiumara. Maria Sola. Cioè questo purtroppo sto in diretta e non posso fare. Ti accattano un paio di scarpe da ginnastica. Non è vero, invece ci sei, siamo contenti, guardano un attimo la telecamera, della commissione ha valutato in modo positivo il suo curriculum della sua tesi, sia per quanto riguarda i contenuti, sia per quanto riguarda le modalità di presentazione. La valutazione è stata positiva, pertanto per i poteri a me conferiti dalla legge, per delega specifica della magnifica direttrice di Sapienza, Università di Roma, la dichiaro dottore di medicina e chirurgia con il voto finale di 110 su 110 con lode. Complimenti. Chiara Tonnarini. Chiara Tonnarini guarda della telecamera. Allora, la commissione ha valutato il suo curriculum, ha valutato anche della sua tesi, che è stata presa in considerazione sia dal punto di vista contenutistico, sia anche per quanto riguarda delle modalità di presentazione dei risultati al pubblico e alla commissione. La valutazione è stata positiva. Pertanto, per i poteri a me conferiti dalla legge, per delega specifica della magnifica rettrice di Sapienza dell'Università di Roma, la proclamano del dottore in medicina e chirurgia con la votazione finale di 110 su 110 con lode. Complimenti. Federica Fruni. Federica Fruni, della commissione ha valutato il suo curriculum, prendendo in considerazione gli esami sostenuti della media curricolare, ha valutato della sua tesi, sia dal punto di vista dei contenuti e sia per quanto riguarda la presentazione. La valutazione è stata positiva, pertanto per i poteri a me conferiti dalla legge, per delega specifica della magnifica rettrice di Sapienza Università di Roma, la proclamano del dottore di medicina e chirurgia con la votazione finale di 110 su 110 con lode. Complimenti. Maria Chiara Ferraro. Bene, Maria Chiara Ferraro, della commissione ha valutato la sua media curricolare, il suo curriculum, ha valutato della sua tesi sia per quanto riguarda i contenuti, sia per quanto riguarda questa è una seduta cioè tutta una serie di disgrazie possibili. Ha valutato in maniera molto positiva, devo dire la verità, sia della sua media curricolare, sia della sua tesi. Ripeto, la valutazione è stata molto positiva. Pertanto, per i poteri a me conferiti dalla legge, per delega specifica della magnifica direttrice di Sapienza dell'Università di Roma, la proclamano di dottore, una di medicina, una di chirurgia, una con la votazione di finale di 110 su 110, una di colloquio, una di complimenti. Maria Chiara, una di Ferraro, a nome di tutti, uno di voi, uno dei candidati, uno dei laureati, uno dei laureandi, uno dei laureati, uno di leggerà il giuramento di Ippocrate. Prego tutti, uno di alzarsi, uno di in piedi, e prego dei laureati, poter leggere il giuramento di Ippocrate insieme a Maria Chiara de Ferrara. Maria Chiara de Ferrara leggono il giuramento di Ippocrate, te lo ripeto ancora, a nome di tutti noi, tutti uno di voi, uno dei laureandi, laureati. Ti prego Maria Chiara.
Affermo con giuramento per Apollo Medico e per Esculapio, per Igea e per Panacea, e ne siano testimoni tutti gli dei e le dee, che per quanto me lo consentiranno le mie forze e il mio pensiero, adempirò questo mio giuramento, che prometto qui scritto. Considererò come padre colui che mi iniziò e mi fu maestro in quest'arte, e con gratitudine lo assisterò e gli fornirò quanto possa occorrergli per il nutrimento e per le necessità della vita. Considererò come miei fratelli i suoi figli, e se essi vorranno apprendere quest'arte, insegnerò loro senza compenso e senza obbligazioni scritte, e farò partecipi delle mie azioni e spiegazioni di tutta intera questa disciplina, tanto i miei figli quanto quelli del mio maestro, e così i discepoli che abbiano giurato di volersi dedicare a questa professione, e nessun altro all'infuori di essi. Prescriverò agli infermi la dieta opportuna, che loro convenga per quanto mi sarà permesso dalle mie cognizioni, e li difenderò da ogni cosa ingiusta e dannosa, giammai mosso dalle premure insistenze di alcuno propinerò medicamenti letali, né commetterò mai cose di questo genere. E per lo stesso motivo non mai ad alcuna donna suggerirò prescrizioni che possano farla abortire, ma serberò casta e pura da ogni delitto, sia la vita sia la mia arte. Ne opererò i malati di calcoli lasciando tal compito agli esperti di quest'arte. In qualsiasi casa entrato, baderò soltanto alla salute agli infermi, rifugiando ogni sospetto di ingiustizia e di usata corruzione, soprattutto del desiderio di illecite relazioni con donne e con uomini, sia liberi che servi. E tutto quello che durante la cura e anche all'infuori di essa avrò visto, avrò ascoltato sulla vita comune delle persone, e che non dovrà essere divulgato, tacerò come cosa sacra. Che io possa, se avrò con ogni scrupolo osservato questo mio giuramento senza mai trasgredirlo, vivere a lungo e felicemente nella piena stima di tutti e raccogliere copiosi frutti della mia arte. Che se invece lo violerò e sarò quindi spergiuro, possa capitarmi tutto il contrario.
Di tutti uno dei professori di questa commissione, a nome di tutti uno dei professori delle facoltà di medicina, di chirurgia e di Sapienza, vi auguro buona fortuna per tutta la vita. Grazie mille e congratulazioni.